Hello, Mr. Gautam.
Yes, sir. Yes, sir.
Can we go live now? I'll make introduction and I will then hand over to Dr. Iyer and then I will introduce Dr. Mrs. Joshi later on.
Yeah. Sir, after 30 seconds, please start.
Okay. Okay.
Participants are only 6. Usme to Kedar is one, Ujjwala Joshi is another, I am the third. Voodoo Conference Technologies is 2, so that's 5. Salim Patutara has come.
Yeah.
So this is faculty link, sir. In that webinar link, already 140 members are there.
Already you have so many people. Fine.
Yes, sir. Sir, it is already live. So please start.
Okay. Good afternoon, everybody, and I think a very warm welcome from Southeast Asia region. On behalf of Dr. Ranganathan Iyer, who is a consultant medical microbiologist and infectious disease specialist based in Global Hospital, Hyderabad. And from my own part, I'm Dr. Kedar Devdar. I'm a pathologist at Tata Hospital, Mumbai. We welcome you all to this technician training program. I'm particularly happy that this program is actually occurring and we have really got an encouraging reply. The idea was, to be honest, conceptualized by Dr. Iyer, and then we thought of some program over 2 days. We selected afternoon time in such a way that this should be actually useful for the people in this region and the surrounding and the neighboring countries. And afternoon probably gives us time for our colleagues, technologists, as well as probably for the trainees in pathology and microbiology, the medical trainees to get some time or maybe some time to themselves to attend these lectures. So we have selected actually a very experienced faculty from Hyderabad and Mumbai. The collective experience actually is really, really very good. They can give us tips or two, maybe multiple tips or two, to be honest. And this, I hope, will be useful to all. I also urge all of us to give feedback, a genuine feedback, and so that we can improve and hold similar conferences or similar training programs for medical doctors, as well as MLSO, medical laboratory scientific talk. I'll just take a minute. So I'm thankful to International Committee of the Royal College of Pathologists.
Kedar, one sec. I'm
sorry.
So sorry to interrupt you 1 minute. Bashir, can you please enable recording for this? It will be important for Kedar.
Sir, already it is recording, sir.
Thank you.
Yeah.
Right.
So again, from Dr. Iyer and myself, I welcome. This is kindly actually sponsored by Royal College of Pathologists, for whom we both are advisors in this region. The program goes
recording
by,
in progress.
It's actually spread over 2 days. 11th is actually histology, cytology, and hematology, and 12th is actually medical microbiology, serology, and molecular diagnostics of infections. So we'll have 2 lectures. First on histology quality issues by Mrs. Ujjwala Joshi. Second lecture in cytology. Then we'll have a break for half an hour, and 4:30 p.m. India for another next hour, hematology, including coagulation techniques. Introduce to you Mrs. Ujjwala Joshi, who's just retired from Tata Hospital as a chief of the laboratories histopathology. We have a high volume center, and she has for more than 30 years. She's also worked in electron microscopy. She's conducted CMEs every year. She has been a president of Association of Medical Histotechnologists of India, and she's an invited speaker for many webinars and conferences, histotechnology conferences. She's actively involved in setting up histology laboratories across various parts of the country, and she's also actively currently involved in writing a book on histotechnology. So without further ado, I will invite Dr. Ujjwala Joshi. But first of all, before that, I will invite Dr. Iyer for a few of his comments, and then Mrs. Joshi can start.
Thank you so much, Kedar. And it's really wonderful to see somebody who, a technologist in histopathology who is all set to write a book on histotechnology with her experience of over 40 years. I can well imagine and that too in a place like Tata Memorial Hospital, where I'm sure she would have been overworked on many, many, many occasions. And she would have had to, and I'm sure she would have been directly in the firing line of consultant pathologists as well as the surgeons on all sides for faster product slides. So it would have been, I mean, it would really be wonderful for histotechnicians and cytotechnicians if you could come up with a very, very useful book covering your experience. Now, to cut a long story short, this was something which we thought of. I've always had something in mind about technologists, benefiting from experience. It's very important because everybody talks to pathologists, to microbiologists, to biochemists, the doctors, the clinical consultants, but then nobody really thinks about who actually does the work in the kitchen. So it's something like the cook in the kitchen goes on cooking, but then what comes up on the table is what everyone sees, but then nobody really sees the work that goes on behind our backs. And that work is extremely important. Without that work, the rest of it is useless. I mean, I'm sure even Kedar would agree with me. If a specimen is not sliced properly, if specimen bits are not taken properly, the bits are taken, biopsy bits are taken, and if they are lost somewhere in that histokinete, or bits of liver biopsies and kidney biopsies are just lost, you can well imagine the patient's condition, the pathologist's plight, and all that the safe handling is so very, very important in all branches
Recording
of pathology. In all branches of pathology. And that is what is extremely important for all of us to remember, that the work done by a laboratory technologist is what decides what is the quality of the report that goes out from the laboratory. And that impacts patient care to a great extent. Very few people realize the importance of this. And if we don't realize the importance of it and tell everyone, who is going to realize and who is going to talk to everyone about it? So with that in mind, I mean, once Kedar took over as the regional advisor, I really thought that we should get together and make this happen. And fortunately, thankfully, he was very, very receptive to this idea. And here we are talking to all our colleagues in techniques, in technology, and in the laboratory medicine technologists group, so that they can take home some useful points. And I'm sure even they can ask some questions. And we are also here to learn, because I'm sure a lot of people have come across a lot of problems while handling specimens, while handling tissues, while handling CSFs in the laboratory. And when they ask a question, it sometimes makes us think, because even we are not very ready with answers for everything. So it will help us go back, read, find out why a particular thing happens or goes wrong in the laboratory. And definitely we could send emails later on, discuss with them on the phone and so on. But then it's something like all of us learn in the process. And it's very important that this is brought to some good platform and listed on the recording of this whole session, so that, you know, it can be shared with those who have not been able to attend, those who are attending partly, and those who would like to review the sessions at a later date. It will be very useful for them if we could share the presentations as well as the recording of the sessions with them at this time. It's with great pleasure that I have been able to able to get this going, and along with Kedar, I'm sure are going to be of a very great learning experience to one and all. Thank you so much.
Thank you. We invite Ujjwala Joshi to start her lecture, please.
Yeah, can I share the screen?
Bashir.
Yes, ma'am. Yes, ma'am. Yes, ma'am.
Yeah, Mrs. Ujjwala Joshi wants to share the screen. She has slides to present, please.
Yeah, we can see the slides now. Yeah.
Yeah. Before I begin, I would like to thank Dr. Kedar for inviting me, Dr. Iyer, and RCP and the whole team, because as Dr. Iyer has rightly said that histotechnologists have always been backstage artists, and here is somebody who is really coming and talking to you on the stage. So I take this privilege to talk to you, share my experiences, and I hope it will be helpful for a new generation of histotechnologists, because histotechnology was as such, it was looked down upon, it was little bit neglected, and nowadays people have realized importance of these techniques after the introduction of accreditation actually. So let me start with my first slide, which shows you the, 1 minute. Let me stop video so that. This is a journey of tissue from OT to pathologist via histopathology laboratory. So starting from sample reception, followed by fixation and grossing, processing, embedding, cutting, and staining, what you get is a beautiful H&E, which shows nice nuclear details and cytoplasm. And I would rate this slide as 5-star, give as 5-star rating. But if something goes wrong at some stage, then you will get something like this, which could be, a 2-star rating. So we want something like this, isn't it? So I will be discussing each and every step in detail. Actually, each step is important. I can talk for hours together on each step, but in short, I'll try to cover and give you little tips, and in details, I'll try to cover. Also, there are some additional aspects which I'll be discussing, that is frozen section, decalcification, and the most important is quality management in histopathology laboratory. Now, before, when I joined this my institution, that is Tata Memorial Hospital, we used to never had these terms in our day-to-day working, like pre-analytical, analytical. But this whole histotechnology is now divided into pre-analytical, analytical, post-analytical phase, and like other branches of pathology. So in short, I have written here just to know the histotechnologies, what is pre-analytical? It is nothing but a technical process. Analytical is nothing but the actual diagnosis given by a pathologist. And post-analytical, which is equally important, which includes filing of your block slides, retrieval of paraffin blocks and slides, because they are required for various things, like supposing you want to take second opinion or you want to carry out certain tests. So let us start our first slide, which is receiving and numbering of samples. And one must understand that the literature says about 70% of errors occur during pre-analytical steps. So you can now understand the importance of this particular step, because you have to double check the case number, name of the patient, you have to verify demographic details of the patient, check information on the requisition form, and use barcode labels. This minimizes errors. In all large laboratories, people use barcode, and but in small laboratories, they still use logbooks where they enter patients' details manually. But don't worry, you have to cross-check. Everything has to be cross-checked doubly. Then the chances of mix-ups are very high. Remember, we are all playing with patients' lives. So every sample has to be handled very, very carefully. Coming to the second most important step is fixation and grossing. I always compare fixation is like a base of the building, If your base is very strong, then your building becomes strong. And remember, fixation is an irreversible process. If something goes wrong, if your tissue is underfixed, nothing can be done, nothing can be rectified later. So let us understand what is fixation. I'm sure all of you know, but let us revise it in a short period. Complex series of chemical events. It prevents autolysis and bacterial attack, that is putrefaction. The fixation should be carried out as soon as possible. This is very important to avoid autolysis and putrefaction after surgical removal of the tissue. So this as soon as possible. Let us see. Now, this fixation time is delayed due to multiple steps. Nowadays, this is another important term, which is known as cold ischemic time, which doctors and surgeons often use, but histotechnicians must know this term. This sample is handled by different people. Each step is time taking and no SOP is available. And that's a very sad story of histological techniques for transport of sample from OT to laboratory. For example, in OT, surgeon handles it, OT desk, OT clerk, then OT sister, OT boy, lab assistant. When it comes to laboratory, then a lab technician, while grossing, a junior pathologist. So imagine this particular tissue is handled by so many people and actual fixation happens by a lab technician. So how difficult it is. When I say as soon as possible fix it, it is very, very difficult. So you have to understand in your laboratory, go back and see how can you minimize this timing, because this time is very, very critical. Coming to fixative preparation, 10% neutral buffered formalin is a general fixative, all of us know. Remember, always freshly prepared formalin is preferred, but in a large laboratory, this is not possible. So you have to prepare formalin. Go on checking pH every day. It has to be neutral or in the range of 7.2 to 7.5. pH must be checked with pH meter and not with a pH paper. Now, in this formalin, if you add a little bit of eosin, that helps in making your tiny biopsies visible. We call it as eosinophilic formalin. Now, there are some important points for fixation and grossing. This point, which I'm not going into the details because this is a very debatable point. Many pathologists feel that the tissue has to be fixed first and then grossed. Many feel vice versa, like it has to be grossed first and then it can be fixed later and then can be taken into a tissue processor. But I'm not going into the details. But for a technician, it is very important to know that when a GI specimen comes, it has to be cut open and fixed in a tray. Remember, many pathologists are, they are in a stage of teaching. Many are, junior pathologists. So it is a technician's job, who is experienced technician, to see if the GI specimens are cut open and fixed in a tray with sufficient amount of formalin. If there is a lymph node, it has to be bread loafed, which I have shown you here. It has to be bread loafed properly. For all specimens during grossing, it is mandatory to draw a picture, write date and time of fixation of grossing and time of fixation and grossing, the number of cassettes, how many cassettes you are preparing out of one specimen, and name of handling person on requisition form, because this is going to give an accountability to that specimen, and each and every point is important, even though it sounds little descriptive. But please see it and apply it in your laboratory. Then later on, it becomes to thickness, which is important. It cannot go beyond 2 to 3 mm, and the entire tissue thickness depends on the processing schedule of your laboratory. For small biopsies, do not give serial numbers to one type of sample. For example, if you have some 10 core biopsies, just don't give them serial numbers. Place some other small sample in between, because if there are two breast samples side by side, and if by chance there is any mix-up, at the time of microscopy, it becomes very difficult for a pathologist to identify, because in a large lab, there are always mix-ups. There is a high chance of getting mix-ups. So arrange your specimens in such a way that there is one breast specimen followed by some other thyroid or other tissues. Don't just bring all the breast specimens together. That is out of our experience, we have decided. Then use one color of cassettes for one case. Supposing you have made some 40 cassettes out of some thyroid, then 100 cassettes of a prostate, then use color coding so that at the time of embedding, when you start embedding, all the tissues will not be mixed up. It is very convenient. Some other important points: lymph nodes, if they are small in a cassette, there should be no cluttering. Tiny biopsies should be wrapped in Botman filter paper, otherwise they'll be lost during processing. Fix the specimens in at least 20 times of its volume. Bone marrow biopsies are fixed in acetic acid, zinc, chloride, and formaldehyde. That is AZF fixative, which is a suggested fixative as far, and in Tata Hospital we use Hammersmith protocol, which is a widely used protocol and which gives excellent results, excellent nuclear staining. So I suggest bone marrows to be processed by using AZF fixative and Hammersmith protocol. Then seropositive specimens to be fixed for 48 hours. If the lesion is seen on one surface only, then mark it with India ink so that it is embedded in such a way that it appears on the cutting surface and the pathologist can see. Actually, I have shown you this. The ratio has to be 1:20. This is how it should be. Then there are many precautions. I have shown here few. Use rubber gloves and mask to prevent nasal damage because you are handling a very toxic chemical called formalin. Must be prepared under hood. Constituents must be mixed thoroughly, otherwise there is the buffer gets solidified and there is a the formalin buffering is not properly done. Adequate ventilation of the room is mandatory. This is a picture of a fume hood which has to be used for grossing. It is nothing but a motor blower exhaust system. What does it do? It generates negative pressure within the hood, extracting all contaminated air, like that is formalin and whatever you are handling with from the working area, so that there is a minimum exposure to a grossing pathologist or a technician. Coming to the third point, that is tissue processing, which is very, very important. All of you know, once the tissue is fixed, it is taken into cassettes and it is processed in a tissue processor. Tissue processing is a procedure of removing water from cells and replacing it with a medium called paraffin wax. This is a generally used medium. This allows thin sections to be cut on a microtome. This procedure involves steps involving diffusion of reagents from and to the tissue, steps involved. And remember, that's the reason why I have told you the thickness is very important. First step is dehydration, that is removal of water molecules, followed by clearing, that is removing dehydrating agents, and impregnation, that is nothing but removing clearing agents. Now, there are certain pre-processing steps. First of all, technicians should know how an underfixed tissue looks like. It looks like this. When the tissue is fixed, it looks like this. It shouldn't be, looking like some reddish color also. Soft tissue, which is cut and it is put in cassettes. These cassettes are dipped in 70% alcohol and this rotor is put in tissue processor. If you have soft tissue, if the tissue is not soft, if it is bony, then you have to decalcify it, and again the same protocol is followed. Now, once the tissue processor does the processing, it is ready for embedding. Dehydration, I'm not going into the details, but you must remember that there are other dehydrating agents which are methanol, butanol, dioxin, and acetone. But absolute alcohol is the most commonly used dehydrating agent. This is costly and hence it is replaced by isopropanol, which is cheaper and it doesn't, compromise the quality of dehydration. Clearing is usually done by xylene. It is an intermittent between alcohol and paraffin wax. There are some other reagents like benzene, cedar wood oil, but xylene is the most commonly used reagent. After clearing, tissue cavities are filled with molten wax. This wax is a supporting medium and the process is known as impregnation. Some other media are paraplast, which is nothing but highly purified paraffin. There are resins, there are gelatins, but nowadays mostly people, even in Tata, we use paraffin wax, which has good resin additives. So here I want to draw your attention to a very big aspect, that is, it is the biggest challenge. What is the biggest challenge in processing? I always compare this. See this picture, people with different nature, age, color, gender are staying together happily as a family. And this is exactly like tissues with different textures, sizes, shapes can be processed together in one rotor with a standardized program. Remember, each tissue requires different tissue processing schedule, but we can't do it. So you have to standardize your tissue processing program considering the following parameters, that is which type of processor you're using, the features which you are utilizing, if your tissue processor has pressure vacuum, stirring, temperature, what kind of grade of reagents you're using. All these things are very important, and hence it is very, very difficult, and it requires experience to come to and standardize the processing schedule. Now the processing schedule should give optimum processing results as different sizes, which I have already shown you. I'm not going into the details. Now, this is something urgent processing. As Dr. Iyer was telling me, I was asked, to give me slides on the same day. Come on, give me within 2 hours. I want slide now because we want to give diagnosis today only, and then they'll be after the pathologist, that they know that after coming to me only, then they can face a pathologist and give a slide. But urgent processing also, technician should know what reagent has to be used for what time and what is the thickness. Now, this is a rough idea which I have given. Total tissue processing time without using any fancy tissue processor, you can process the tissue within 2 hours, but you must know the principle behind it. Overnight tissue processor, which is 14 to 15 hours. This is also a rough. And whenever I have written ethanol, you can replace it with isopropanol. But there is a little difference between using ethanol and isopropanol. Of course, ethanol is a better one. So you standardize processing schedule for your own lab. There are certain safety issues. Reagent transfer must be done under fume hood. Same reason I have told you. Reagent should be stored away from machines in a safe place. Now, if some lab is going for accreditation, this is very mandatory. Have sand buckets in the processing room. This is not only mandatory for accreditation view, but this is required for your laboratory, for your technicians, and for better results. Processing room should be separate. It should be away from rest of the lab. This maintenance part, I'm not going into the details, but every machine has to be maintained. The technician has to be trained how to handle it, the troubleshooting, and maximum, this is my experience, that if something goes wrong with the tissue processor, the main reason is due to mishandling, because the technician doesn't understand. He has not read the manual properly. Another important aspect is grade of the reagent. What is grade? We suggest that AR or XLR grade, that is ultra pure, should be used in the tissue processor. Laboratory LR grade is usually used for training purposes, and GR is guaranteed reagent. But LR is usually not used. People where there is a constraint of budgetary constraints are faced, the people have used different reagents, but then they are compromising the quality of tissue processing. When you are asking for certain reagent, please ask product code, MSDS, that is batch number, material safety data sheet, and it is available online also. So it is very, very necessary to have MSDS for each and every reagents, and it ensures that whatever reagent you are using is pure. About chemicals used, I have told you, this is just, I want you to read this about additives. It's nothing but blend of paraffin wax, and it has several advantages. Why we are using additives? It provides excellent elasticity. This gives thin compression-free ribbons. This provides maximum support for both hard and soft tissue samples. Low melting point waxes, if they are used, then it eliminates excessive heat distortion during tissue processing. And DMSO added to blend of wax, it decreases impregnation time and facilitates thin sectioning. There are some examples like beeswax, rubber, sericin, plastic polymers, and diethylene glycol distillate. So these are some of the additives. Coming to the important aspect of troubleshooting, every technician should be aware that if the tissue is soft after processing, then it is either under processed, or you have used a short program, or you have not done proper leveling of reagents, or there is a fixation problem. Unfortunately, in these histological techniques, 1 + 1 is always not 2. You know, you cannot say that, yes, this is due to this, or this is due to, there could be several reasons, and you have to identify, your lab manager should identify the exact reason for it. This looks, if your tissue looks hard, then it is naturally over processed. You have to apply a little bit of logic and then troubleshoot it. Or you have used elongated program, or your tissues must be dried at some stage of processing. Supposing your tissue separates from block, you know, sometimes you see like this, it is due to poor impregnation. In such a case, you melt the tissue, then put it in the molten wax for at least 3 hours and reprocess it. Many times, you know, if you use the rotary type of tissue processors, because many laboratories still use it. I don't, if the budget is allowed, but budget is available, then don't go for this type of tissue processor. I always suggest you to use the compact tissue processor, which has got many facilities. So basket of tissue processor, if it is stuck up in the air, then you can't do anything, because this is a mechanical problem. You have to call engineer, and your tissues get dried overnight, and then it is, you know, it is absolutely impossible to recover such tissues. If your tissues look burnt, then this may be due to paraffin wax, excessive temperature of paraffin wax. That is why NABL insists that you have to record every day the temperature of paraffin bath. Tissue ribbon is disintegrated at the type of spreading. This is our experience, because we get lot of material for second opinion, because TMH is a tertiary referral center. So we get variety of tissues, you know. Some are under processed, some are over processed. So usually what we have seen is, if the tissue is under processed, then there is the ribbon which is, you know, disintegrated. So you have to reprocess it. Back processing, I'm not going into the details, but you have to remember this, that it cannot be done if there is improper fixation, or if your tissues are hard, if your tissues are burned. You can't do anything. Back processing may damage the tissue. Do it only if it is necessary. Sometimes tissue looks soft due to insufficient impregnation, and I have already told you what to do about it. Back processing is not the solution for all badly processed tissues. You have to remember this. Coming to the fourth aspect, that is tissue embedding. It is the process by which the tissues are surrounded by a medium such as agar, gelatin, or wax. Here we are dealing with wax. The harder the material, the thinner the section. So the soft tissues, you're making it hard so that it can be cut on the microtome. This, I have told you, a flow chart, where this is called as a, I'm sure all of you know this, but just to refresh your thing, you have to put the tissue in molten wax, press it a bit, then apply, pour with the help of machine more molten wax, put an embedding ring, and then if you're using embedding ring, fine. If you're using a plastic cassette, instead of embedding ring, you can put a plastic cassette, just press it and allow it to cool it on a ice tray, or, you know, on ice, over ice, and it is detached, you know. If you're using an embedding machine, it has got a lot of facilities, that you have a digital display, you have a paraffin reservoir, you can place, you have a forceps which is, you know, constantly heated, then you have mold warmer, and you have a cooling plate. So if you're using this, otherwise you can use a simple kettle in which you can store liquid paraffin and use it. Orientation of tissue is another important thing, where multiple and tiny tissues should be embedded. The procedure has to be carried out very quickly, because the molten paraffin is getting solidified very quickly. So there will be layers formed if you are not doing it quickly. And then at the end, some tissues will be embedded down, deep down, and only some will be superficial. And that's the reason why all the lymph nodes should be placed at same level. Do it very quickly, and it has to be done. It has to be placed only few millimeters apart with a parallel placement, parallel to the edge of the mold. Now, all flat intestinal margin should be placed horizontally with ink surface outside. Tissues with an epithelial surface, such as skin, are embedded to provide a section in a plane at right angles to the surface. Multiple tissues are aligned across the long axis. Tubular and walled specimens such as cysts and GI tissues are embedded so as to provide transverse sections showing all tissue layers, Otherwise, pathologists will come to you, say it, and they ask for 90-degree turn, you have to melt it, turn the tissue, and that will, kill a lot of time, and the diagnosis will be delayed. So please do it. When you're doing it at first shot, only do it properly. Coming to the fifth, trimming and cutting. Different types of microtomes are available. All these different microtomes, sledge, sliding, everything is given in the textbook. But what we use is a rotary microtome. About cutting knives and blades. Nowadays, knives are not used many times. In many laboratories, you use low profile knives or high profile, not knives, blades. What are they? Low profile blades are used to cut routine thin sections. High profile blades are used to cut harder sections. You can use both, but you should know this profile. This is a C profile, which is generally used. That is a wedge knife. This is, supposing this is the edge of the knife, it is like this. This kind of C profile is usual, but there are other profiles also which are available that you should know. This is just to give you a comparison of angle of low and high, then thickness. Can you see this? High profile is little bit thicker, and the edge width is different. So this helps you in understanding what is angle. About sharpening of knives, there are two steps, honing and stropping. Nowadays, very few people do it, but what you must remember is honing is going to grind your cutting edge, and you getting rid of nicks what are there. After a lot of use, you get what is called as nicks. So you have to do honing if you get nicks. And stropping is nothing but polishing of knife. Coming to the steps before cutting, that is, first is trimming, that is shave off excess of paraffin. Then before cutting, you cool the block for 10 minutes over ice, insert the blade, tighten all the screws, select micron thickness, which is at 4 to 5, adjust it, and then start cutting. Precautions: do not over trim, otherwise there are chances that the tissues will be lost. Do not under trim, otherwise some area will not be exposed. Trim the block slowly to avoid holes in the sections. Coming to the angle, what I have written here is what is written in the book, but adjustment of microtome angle is nothing but which comes only after experience. If you are sitting on a microtome only just one day before your exam, this is applicable for junior pathologists. I have seen them coming only just a day before in the laboratory. Kaise karna hai? You just show me. It is not possible, because understand first what is bevel angle. It is this angle, the edge, it is usually 25 to 30. It is the cross edge of the knife, this bevel, which is not adjusted every day. This angle from the side of the blade to the cutting edge, in general, the angle between the two sides. These two angles are very important. Second angle is clearance angle, which is 5 to 10 degrees. And this, what I mean is, when you adjust microtome angle, you have to adjust this clearance angle. Now, when you actually cut the blocks after cooling it, you get serial sections. If everything is properly done, you get serial sections. With the help of razor blade, you cut one section and put it in a dilute of alcohol where you get rid of your major folds. Then take it on a glass slide, spread it in a water bath, gently press it between the papers, number it, put it in the staining rack, and allow the water to drain. Heat the slide before staining for minimum 10 minutes at 60 degrees. Coming to the troubleshooting, please pay attention because this is applicable to frozen section cutting also. Now, there are certain cutting problems occur due to improper embedding. There are partial section tissues. Most important thing is holes in the sections. If you trim it very harshly in order to finish your workload, what you get is holes. This kind of holes, if you want to get rid of it, just place the block again and slowly start trimming it again. All these holes will disappear. Coming to improper dehydration. If you see those chatters, this is due to shrunken tissue. If you're using a very pure alcohol or many changes you're giving to of alcohol you're giving, then what you see here is you can get chatters. Then if you don't get complete section, it is due to bad quality wax which is used. If tissue looks dry, rotors are struck, in that case you can rehydrate the tissue. This is very common. You get thick and thin sections. It is due to either your screws are loose, your knife tilt is not proper. In that case, you have to adjust knife, which I have told you in the previous slide. Sometimes your knife cuts deeply in the block. This also is due to loose screws. So you remember before start your cutting, tighten all the screws. Torn sections, knife has nicks, or there is some hard part in the tissue, or sometimes the pathologist has forgotten to remove the staples or pins. The curling of sections is due to, again, wrong knife angle. Now there are folds. During staining, you can see this due to improper temperature of water bath. The water bath temperature has to be just less than the melting point of paraffin wax. Sometimes your sections are getting separated. Sometimes your sections are compressed at one end. All these technicians must have seen. Sections are dragged off the back edge. This is just due to wrong knife angle. So how important to adjust the knife angle. Coming to the sixth H&E staining, that is hematoxylin and eosin. There is a good distinction between cell nucleus and cytoplasm. I am not going into the details of the principle, but this is very important. You just should not know that the hematoxylin gives blue color and eosin gives pink color to the cytoplasm. Only that much is not sufficient. You have to remember and understand the principle behind staining. Hematoxylin, and which is the most commonly used eosin, it is eosin Y. And Harris hematoxylin is the most commonly used hematoxylin. There are other types of hematoxylin also, that is alum hematoxylin, iron hematoxylin, which is generally used for special stains. What is bluing? Bluing is equally important because if you don't blue the section properly, then due to wrong pH, there is a sometimes you get on the section a reddish tinge, because, and then the pathologist feels that there is something wrong with staining. So that something is nothing but wrong bluing. So remember, under a tap water, you have to blue the sections well for 5 to 10 minutes. Reagent preparation, another important thing, you must know when to add and what to add. You have to, best thing is to prepare your own Harris hematoxylin in the laboratory. Sometimes you're in a hurry, pathologist requires slide within 5 minutes. Can you do it? Yes, you can. There is something called as a rapid hand staining, but do it carefully, understand how to do it, and then only do it. Two types, everybody knows, progressive and regressive. Generally, progressive alum hematoxylin may be used either progressively or regressively, but progressive tissue is left just long enough to reach proper. For example, in frozen sections, you are always in a hurry, patient is on the operation table, so you use progressive type of staining. Regressive is always better because tissue is deliberately overstained, and then you differentiate. And you can, when you're doing a manual staining, you can control this step. So regressive staining is always better. Staining schedule, again, exactly like your processing, what kind of staining machine you're using. If you're using manual staining, everything, supposing your textbook or somebody has told you that put it in hematoxylin for 6 minutes, I don't agree with this, because this is not the thing which you have to follow. You have to do it by yourself. And just because books tells you that it put it in hematoxylin for 6 minutes, it's absolutely wrong. It depends on what hematoxylin you are using, how old is it, and what type of staining you're using. So just don't go by the books or somebody. You have to learn it by yourself. Restaining is always possible if you have the slides which have faded over period of 2-3 years. Quality control is must at the end. Quality control of staining, I mean, prepare a control block, because in lymph node, you have lot of lymphoid tissue. In fatty tissue, there is lot of connective tissue or fat, or you can choose a tissue which has a lot of connective tissue. And then grade your laboratory manager has to grade. This indicates poor. If your staining is poor, a laboratory manager has to tell a technician that immediate corrective action has to be taken. Then +1 indicates fair, +2 good, and +3 excellent. Followed by your lab manager, pathologist has to verify this. Quality control every day for every cradle. It is mandatory, and then only submit the slides. Coming to troubleshooting, first thing is first point is you see a lot of patches, The cause is due to improper removal of paraffin. You have used less amount of xylene. Then in such case, you replace your xylene, this will go. There is dye precipitate, because you have not filtered your hematoxylin. Every day in the morning, you have to filter hematoxylin. This eosin flakes is a very common thing nowadays, because eosin flakes are the keratin of skin, which is exfoliated, and if the technician is applying with the finger, then you can see it. So please use cotton buds. If your processing is absolutely good, in Tata, we don't use egg albumin at all. Because we are sure that we are cutting thin sections. Light staining, you have to check your hematoxylin, and there are so many other points also, and the remedy is increased staining time. You're differentiated properly, or if you're doing it in machine, then check your acid alcohol timing. If the staining is dark, again, differentiate it, use lesser strength of hematoxylin and differentiate it more. If your slides are foggy, sometimes you see it, after finishing if your dehydration is and clearing is not proper, your slides look foggy. This is something, which a pathologist is irritated, because you see a bubble, and at the time of diagnosis, if somebody sees like this, then you're irritated. So make sure that your clearing agent, your mounting agent, that is DPX, is proper. Its consistency, sometimes it's very watery, because there is a lot of xylene content in it. So quality of reagent becomes important. Nowadays, there are automatic cover slipping machine. Again, technician will have to know how to handle it. Otherwise, this is of no help if you don't know how to do it. Hand mounting is the best mounting. But in conclusion, I can say hand staining is good for small type of workload. H&E can be carried out in bulk by automatic staining machine, which gives accurate and consistent results. Differentiation and intensity of staining can be standardized. Variability in staining depends on many factors like age of stain, batch number of dye, thickness of section, type of processing. So when you are looking into the problems which have occurred, you have to see, and you have to first think logically, and then go deep into the problem, try and understand the problem, and then try to solve it. Always discuss it with your colleagues. Coming to the next important topic, frozen section. In Tata Hospital, we do a lot of frozen sections. Sometimes we cut 40 to 50 bits in a day. So our technicians are very, very busy. Principle, I'll just refresh, 60 to 70% of the tissue is formed by water. If frozen, this water is converted into ice, making the tissue hard and providing a self-embedding material. So instead of Paraffin wax, you have a water. Precautions. These are very important because I have written here, frozen sections are done on unfixed tissue, and that is why it poses a high risk. Defrosted and decontaminated with tuberculocidal disinfectant, PPE, such as gown, puncture, and penetration resistant gloves and eye protection must be worn when performing cryostat disinfection procedures. Disinfect knives before reusing by soaking in disinfecting solution. 70% ethyl or reagent grade alcohol can be used to clean the cryostat and provide some disinfection capabilities. This is the link which I have given you for chemical disinfectants. Now, following disinfection, all parts must be thoroughly dried with absolute ethyl alcohol. You have to follow this because this is something which is risky for yourself. Here I have just given you the workflow which everybody knows. Now, tissue is grossed by pathologists. It is called chunk in a cryostat. So I'm sorry, it is chuck. You put this tissue on a chuck. Tissue is frozen and pressed, and then it is cut. Then there is a rapid staining, which is Dr. Kedar. I'm having little more time now. Okay. Okay. So now
we have about 7 or 8 more minutes. Yeah.
Okay. Okay, fine. I'll try to finish in that. So now collect it on the slide and then stain it nicely. You have to use our first toluidine blue and then hematoxylin eosin. Coming to decalcification. Now, if you have any questions regarding frozen sections, you can ask me by the end of this lecture. Little bit about decalcification. I thought it is very important because in Tata, what we use is decalcification. We get about 100 tissues for decalcification every day. So it is important for us to, do it with a great speed. Otherwise, the tissue diagnosis is delayed. So what we use is simultaneous fixation and decalcification. This is something which we prepare 10% formol nitric acid. So at the same time, the tissue is getting fixed and the decalcification procedure also starts. And there are machines which I have shown you, which hasten the decalcification process. Now, hard tissues has calcium. What is it? It has to be removed, which interferes sectioning. We need to remove calcium, and this is nothing but decalcification, usually done by nitric acid. So what is the procedure in short? Fix it first, decalcify it with 10% nitric acid. This is for hard tissues. Wash it overnight. This is very important. Otherwise, your nuclei will not take up hematoxylin properly because you have not washed it for sufficient time. And then process this tissue. Bits which are not very hard, like tracheal cut margin, you have to do light decal, and is instead of 10% nitric acid, you use 5% nitric acid, which is simple. You can't, in Tata, we can't use EDTA, even though it's the best decalcifying agent, because the EDTA is very, very slow. You have to remember adequate washing, I have told you. Incomplete decalcification will interfere in cutting, and therefore this tissue needs to be reprocessed. Excessive heat during decalcification should be avoided, otherwise morphology will not be crisp, and you can't use more than 37 degrees for decalcification. And we all the labels, which are put in nitric acid, there are chances they are torn during decalcification. So what we do is just dip the labels in molten paraffin so that it protects the number, and there are no mix-ups, right? This is the AZF protocol, which we follow, Hammersmith protocol fall. This is a little bit modified by us with our experience, and we save one more day for submission of bone marrows. Coming to quality control program. Now, I am a person who has seen laboratory before accreditation and after accreditation. So what we used to have, and there is a tremendous difference quality-wise in the quality of my laboratory, quality of functioning of the procedures. So remember, there is internal and external quality control. Internal quality testing is usually in-house. You have to check. It's a laboratory manager's responsibility to check the procedures, update the procedures every time, and it ensures a continuous monitoring procedure in a day-to-day operation. External quality control, which is also important, it involves assistance from other laboratories as well as the participation into national or international inter-laboratory sample and data exchange programs. Data from all participating laboratories are collected and presented as a report to show perfectness of the laboratory into, which involves comparing the lab with peer labs, checking whether the performance is below the minimum standards. So actually that laboratory, the reference laboratory, they grade you and tell you where you go wrong. So this kind of quality control we never had previously. Nowadays, for accreditation processes, you're not only for accreditation, for a good, better functioning of your laboratory, this kind of quality control programs are absolutely mandatory. Now, what in a histopathology laboratory, it is necessary to check for a laboratory manager, because usually laboratory manager is has been selected from the laboratory technicians pool only. With the experience, he has become laboratory manager. So you have to check you have to design a quality program to monitor all components of laboratory procedures, like correct numbering, adequate fixation, sufficient processing, appropriate embedding technique, identify artifacts during microtomy, inspecting controls. You have to run controls for every IHC test, for every special stain test, and see that your SOP, standard operating procedure, is well maintained. You update it whenever you update the procedures. Whatever is written in your SOP has to be followed by the lab. You have to have good equipment manual. You have to record daily temperatures. So these are some of the checkpoints which I have written, but there are many more checkpoints also. And I thank you once again for hearing me patiently, and I hope that this has helped you. Thank you so much. Can I stop sharing, Dr. Kedar?
Yes, please. Yes. Please.
Yeah.
Ujjwala, thank you so much. Actually, this is very comprehensive and very hands-on. Shows your experience, because you took many points which are actually not even in textbooks, but reading in between the lines. I thank you again, and thanks a lot.
Thank you.
I have actually multiple questions up on the chat, but maybe I'll try to group those, and some of those are pertaining to PAP staining, so then I can leave it for the next lecture. But I can ask you about, there was a question about how to discard formalin and how do you adjust pH of the formalin?
Okay. Actually, waste management is a topic which I have not covered due to time constraints, but waste management is equally important. Now you can, in Tata, first I'll tell you how we do discard it. We store it in a can and give it to the agency, which will come and collect all the cans, and then they take care of that. But such agency should be, a pollution control board. It should be decided. It should be authorized by Maharashtra Pollution Control Board, and your management has to be backing you for this. So, but formalin can also be. Previously we used to discard formalin in sink, but before discarding, you have to neutralize it. So, but I won't suggest that, because it depends on your laboratory size. If yours is a very small lab, you can neutralize it and put it in sink. But for a large laboratories, you have to give it to an agency which takes it over, and then they take it and incinerate it. So like all other chemicals which are given. And what was your second question?
How about how do you adjust pH of the formalin?
Okay. Now what we use is we use two buffers, right? So you have to adjust formalin either with the help of HCl NaOH and with the help of pH meter. Supposing there is a very small lab and you don't have a pH meter, you have to use a pH paper and at least check with pH paper if it is in that range. But just don't leave it, prepare it and then use it. Please don't do that. You have to check pH. You please see, because if your formalin, you keep it like this, it becomes acidic. And what is formed there is a formalin pigment, which will interfere. So avoid preparation of, avoid this formalin pigment preparation making. I mean, you have to check pH for that.
Okay. It was actually a question about what is the procedure for urgent processing. Maybe that is a longer question or longer answer. May I suggest that that they can write an email to you and then they can.
Yes, and in one of my slides, I have shown you urgent processing can be done within 2 hours.
Yes,
so you can follow that. It is absolutely, but remember I have told you the thickness of the tissue is important. Then only you can follow that. You will get a very nice section.
Right. I think I can, what I can say to the registrants or delegates is that they can take, I mean, Dr. Iyer's address is on the form.
Yes.
Take my email address, it is kedardeodhar@hotmail.com, kedardeodhar@hotmail.com. And if there is anything important or particular related to quality issue, I can ask the relevant expert and then maybe that person can respond to you. Maybe that's a better idea. Because otherwise it may take another 10, 15, 20 minutes for.
Yes, because they can even email me anytime. I am ready. I am ready. I will reply. No problem.
So we will do that.
Okay.
Another question was, which was actually, one of the person and actually very rightly said that don't call us technicians. We are laboratory technologists. And I think it's very, very appropriate because, in many parts of the world or even in UK, the designation is Medical Laboratory Scientific Officers or MLSOs. In fact, when we were talking to Royal College of Pathologists, they don't understand these terms and they said we always call is MLSO or Laboratory Scientific Officers. In cytology in our country, we know that there is also, in addition to technical aspect, there's also interpretation aspect. After somebody passes an ISC exam, Indian Academy of Cytology exam, the person is allowed to screen and interpret. So those are called as technologists rather than technicians. A variety of aspects are involved, in not only technical aspect, but also interpretation aspect and some amount of comments or advisory aspects are attached to it. What is the role of neutral buffered formalin in histopathology, and what are your comments on that?
It's a general fixative. I mean, if there are mercury fixative, there are so many other fixatives which are available, which you can use it. But if you use mercury fixative, you have to remove mercury, right? So that's again a tedious procedure. When you use a neutral buffered formalin, then you are sure that there is no acidic pH to it because you're adjusting pH. And formalin is a known fixative for, the high-end tests like molecular testing and even immunohistochemistry. It will not interfere. But if you use something like mercury fixative, or if you use picric acid for that matter, there are literature there are papers which have said that, it will interfere. So the safest thing is to use 10% formalin, which is buffered. So neutral buffered formalin. So best thing is to use that.
Okay. There are questions about lumpectomy margins, and I think maybe we will leave that question aside because that pertains to kind of processing matter. But I think maybe we can stop, Ujjwala, and I really, from the bottom of my heart, thank you very much for your lucid presentation. You spoke well and gave us very helpful practical tips. So thank you so much again.
Thank you, Dr. Kema.
We'll go on to the next lecture. You may continue to listen to other our.
Yes, sure.
Let me take a moment to introduce the next speaker. I'll share screen now. So our next speaker, can we all see the slides?
Yes, sir.
Can we see the slides? Okay, our next speaker is Mrs. Salim Patuthara. who's a lab manager at Division of Cytopathology at Tata Memorial Hospital, which is a high handle volume containing a laboratory. Salim has more than 25 years of experience. He was a topper in BSc in zoology in Kerala. Then there are various accolades. The list is actually long. What I can say is that there was a cytotechnologist training exam that we conduct every year. He stood first in that. He also is a recipient of Sushil Malhotra Award for the first rank in National Exam for Cytotechnologists, which is conducted by Indian Academy of Cytology. The Indian Academy of Cytology every year conducts a National Cytology Conference, and he has won best paper, which is called as Jwala Devi National Award in that. He's a co-author and best diagnostic paper award in Cytocon in 2018, 2019, second prize later on also. Co-author in Nalini Bai Thakkar Award in 2018. He has various chapters. He's chapters to his credit. He's editor of a comprehensive manual of cytotechnologies 2017 and editor of first edition of synoptic reporting in cytopathology published by Tata Hospital in 2018. He is a member of gynecological and urological disease management group in our hospital. He has been a quality manager, looked after the quality issues in the lab for accreditation ISO 15189 matters for nearly 8 years. Now he has passed on the mantle to some of his colleagues. He's coordinator for external quality assessment program, which we run, and there are more than 400 plus applicants. So there's a vast experience, and I can't have a more better person than Salim to talk about cytology sample processing issues, staining issues, cell block preparation, and so on and so forth. So Salim, over to you, please. Thank you. Yeah, you may share the screen and start. Salim, you're on mute. Mr. Bashir, Gautam. Mr. Bashir Gautam.
Sir, already done, sir.
Yeah.
I share.
Yeah. We can hear now. Salim, unmute kar dijiye.
I'll share. Sir, can you hear me?
Yes, we can hear.
Okay.
Yeah.
Thank you, Dr. Kedar, and also Dr. Ranganathan Iyer for giving me this wonderful opportunity. This was really indeed an honor. And today my topic of discussion is collection and processing of samples for cytological examination. Before going to my lecture, I would like to declare this thing. I have no conflict of interest to disclose, no financial or other interest or gain of any kind with regard to this presentation. Coming to sample processing in cytology, as everyone knows, optical diagnostic yield depends on proper and careful processing of samples. For accurate interpretation of cytology samples, smear should be of monolayer quality without any air drying artifacts, without any obscuring hemorrhage in the smear, and optimal staining quality should be there, and no and quality control aspects in every stages of the smear preparation. Now, there are various types of samples received in the cytopathology laboratory. These include fluid samples such as pleural, ascitic, pericardial, and intraoperative samples, peritoneal washings and pleural washing, CSF, urine, bronchial lavage, antibronchial lavage, bile, sputum, and all these samples are received as samples and which need to be processed before further subjecting to staining and interpretation. Whereas FNAC, penile aspiration cytology smears, cervicovaginal smears, GI tract brushings, oral scrape, nipple discharge, bronchial brushing, and common bile duct brushing. These are the brushing smears which have been collected at the time of either examination or at the time of scopy, and prepared smears are received in the laboratory, and they are just collected and put in the fixative, and we have to further stain that. Now we will discuss about the sample processing of all these samples, pleural, ascitic, and fluids, and sputum, and various other samples. So coming to the fluid samples, the collection and transport of the fluid samples. So the fluid samples has to be collected in a clean and a dry container, preferably in a screw-capped plastic bottles, which ensures there is no spillage or breakage during transport or during the processing. And glass bottles are never used now in Tata Hospital. And after collection, the samples are collected either in the OT or in the OPD, and the samples should be sent to the laboratory as soon as possible. And if there is a delay expected or the delay is unavoidable, refrigeration of the sample is recommended at 4 to 8 degrees Celsius, that is in the normal fridge. Then coming to the preservation, fresh sample are preferred over a preserved sample or preservative added sample. We don't advise any prefixed sample. Prefixation can be done by putting 50% alcohol into the sample. This is not recommended because of the protein coagulation and interference with the further smear preparation. And anticoagulants are added, that is just like ADTA, and this is also not recommended. This also interferes with the further preparation. Coming to the prefixed samples, the disadvantages are that this prefixation coagulates the protein and the cells will round up and it interferes with the cell adherence on the slide. Whereas anticoagulants added can interfere with the sediment formation and further cell block preparation. Fresh samples are always good, and the advantages include layering of the cancer cells in the Buffy code and better cell adherence on the slide and better preservation and thereby better morphology. Coming to the preparatory techniques, I will be discussing only, there are two types of techniques, that is conventional technique and the liquid-based cytology. I will be discussing only on conventional technique because LBC is again a vast subject, so we will restrict our talk to only conventional techniques. Now, all processing is done inside a biosafety cabinet. All cytology samples are processed inside a biosafety cabinet, and usually we use a class 2 type A2 biosafety cabinet, which indicates, that class 2 type A2 means 30% of the air is exhausted and 70% of the air is recycled. And there is a HEPA filter inside the machine, which filters all the microparticles and bacteria. And there is a UV light facility to disinfect the surfaces and all. There is an additional virus burnout facility. In addition to biosafety cabinet, the personnel also will wear personal protective gear such as gloves, masks, and aprons. Now, once it reaches in the laboratory, once the sample reaches in the laboratory specimen identification is verified, that is patient's name or the case number, and also it is documented that the date and time of collection and the date and time of receiving and the date and time of processing the sample. And also we document the volume of the sample collected as well as the volume of sample received. It can happen that 1 liter of the sample is collected and probably we are receiving only 0.5 ml of the sample. So this is a very mandatory thing. And of course, we also note the color and the consistency of the sample and its temperature condition, whether the sample reached at a room temperature condition or whether it was a refrigerated condition. And also we note that whether the sample is a repeat sample, same patient, second sample is coming, or this is a altogether new sample. And CSF samples are usually collected in cryo vials. These are the small 2 ml capacity plastic vials, which are disposable and for only one use. And this is clean vials. These are used for the transport and collection as well as transport of the CSF samples. Coming to the gross appearance of the serous fluids can be sometimes hemorrhagic or seroscitinous. It's like commonly indicate the malignant potential and malignancy, possibility of malignancy. Sometimes the fluid is clear, straw colored or yellow or serous. And usually the reason behind is portal hypertension, cardiac failure, and nephrotic syndrome. Sometimes fluids are cloudy and turbid, indicating infective process. And sometimes it is chylous, indicating the obstruction or injury to the large lymphatic channels, and a mucoid almost always indicates a mucinous neoplasm. So what is the optimum quantity to be required for the processing of the sample? We recommend to send the entire volume over the part of the specimen. Entire volume is a good choice because we can decide how much sample we require for cell block and even for cytology. Then if a small portion of the representative part of the specimen is sent to the laboratory, first we have to shake the entire amount, well shaken, so that it will be homogenized. Then a representative amount, that is about 20 to 30 ml of the sample, which is considered optimal, can be sent to the laboratory for processing. Or in sometimes, it won't be 20 ml, the entire aspirated amount will be just a 1 ml or 2 ml. In such a case, whatever is the minimal fluid tapped or aspirated should be sent to the laboratory. In case of urine samples, 15 to 20 ml fresh voided urine samples are collected. Whereas in case of CSF samples, usually we receive, the samples are collected in minor OT or bone marrow OT, and we receive 0.5 to 1 ml sample for the cytopathological investigation. These pictures are showing the gross appearance of various fluids. This is the urine sample and this is the various serous fluid samples. Coming to the processing, routine processing, sample, as I told you, the sample, all the samples are potentially hazardous, potentially infective, we can get infection. So we have to take all the precautionary measures, and samples are handled inside the biosafety cabinet, and the person who is handling the sample should wear personal protective gear such as gloves and mask. And first we have to stir the sample with an applicator stick very thoroughly so that the sample will be homogenized. And this will facilitate homogenization as well as prevent the coagulation. And also it will remove fibrin and clots by twisting the applicator stick. It will be easy to handle further. And the second step is dividing the sample, representative amount of the sample equally between two centrifuge tubes of 15 ml capacity. These are the plastic centrifuge tubes with a screw cap, and these are ideal to prevent. We always prefer to use plastic centrifuge tubes so that it will not break at the time of handling or in a centrifugation. Screw cap plastic bottles and spillage, breakage, and aerosol formation is prevented. And before putting into the centrifuge tube, we have to balance it thoroughly or balance it properly so that there won't be any breakage or any spillage. Now coming to the second step, that is the loading of the centrifuge machine, and we have to put the tubes in the opposite chambers, centrifuge chambers, and it is put in the centrifuge machine, and the lid is closed, and it is spin at 2000 RPM for 10 minutes. And the daily disinfection of the surfaces of the machines, that is centrifuge machines with 70% alcohol, and periodic calibration of the speed and timer of the centrifuge is necessary for giving consistent results. Now coming to the smear preparation technique, we can have 3-4 methods. One is the cell button method. When there is a cell button after the centrifugation, if there is a visible cell button, we can go for the direct preparation method. This can be either with a plaster pipette or a swab stick. And if there is no sediment after centrifugation, we will go for situ centrifugation. In hemorrhagic fluids, we will also make an additional smear of saline rehydration preparation. And in mucoid sediments, we make crush preparation. So we'll go one by one. First of all, before making the smear, we have to label the bottle. This is the bottle. This is a Copeland jar, plastic Copeland jar, which contains the fixative. The bottle has to be labeled with the specimen identification, and the lid has to be kept open. Therefore, it is closed, so you have to open the lid and keep it open so that the smear can be received immediately into the bottle. And the second step is, so take a slide and etch the laboratory number, or write the laboratory number with the help of a diamond pencil so that it is permanently etched on the smear. Then go to the next step, and after centrifugation, the centrifuge tube is slowly tilted into another tube so that we can decant the supernatant. While decanting the supernatant, care has to be taken that the sediment is not, it has to be done very slowly, that the sediment is not disrupted. And using a pastel pipette, this is the pastel pipette method. Using a pastel pipette, take out the material, that is the sediment material, from the buffy coat, and put the material onto the glass slide, and using a swab stick, just to rotate the material on the sphere in a clockwise pattern or anti-clockwise pattern, and immediately put it in the fixative bottle. Then what is the disadvantage of this material? It can happen that when we are using this, even when we are using the pastel pipette, it can happen that material can accidentally get into the pastel pipette, and quite often the material pumped out will be more, so that the resultant smears are quite thick, and it is difficult for screening. Now coming to the next method, that is swab-stick method. This is the method we have practiced at Tata Memorial Hospital. Most of every smears we are making with the swab-stick method, and this is the cotton applicator. This is an applicator stick which is wound with a little amount of cotton at the tip. The amount of cotton has to be adjusted. We should not use large amount of cotton, nor we should use less amount of cotton. It should be minimal amount of cotton just to make a smooth smear making purpose. Now, as usual, first step is decanting the supernatant. Slowly decant the supernatant into another tube, and taking care that the sediment is intact. And next step is inserting the swab stick inside the test tube slowly, and it reach the sediment. Using the swab stick, take out the sediment from the bottom and just rotate the material on the roll the material on the glass slide and make a smear. And care should be taken to ensure the horizontal position of the centrifuge till all the smears are prepared. Otherwise, the material will be again going back, and it will be difficult to take out the second level of material. Then, what are the advantages of swab stick method? We can get an evenly spread smear, that is the monolayer smear, almost monolayer smear. There is minimal cell loss. And care should be taken to optimize the amount of cotton on the swab stick. That is very important. Now, coming to the clots and mucinous sediments, if the sediment is very mucinous and the blood clots are there, we can crush it between two glass slides, and then using a sub stick or using a applicator stick, we can spread the material. So this is another way of making. Now, coming to the next level, that is, if there is no sediment or if there is a very little scant sediment at the end of the centrifugation, how will you go about? Now you can see this is very scant sediment. This is not, cannot be retrieved from the side. It is difficult to retrieve from the tube, and there is no visible sediment after centrifugation. This usually occurs in serous fluids of sparse cellularity or urine and CSF. These are the usual samples which give sparse cellularity. Then the method of choice is cytocentrifugation. What is the principle of this is the cytocentrifuge machine. What is the principle? Cells which are denser than suspended fluid is thrown directly. It is thrown directly onto the slide due to the centrifugal force, while suspension medium or the supernatant is absorbed by the filter card, resulting in a monolayer of well-preserved cells within 6 millimeter diameter area. So this is a very good method, and we get a very good monolayer smear by using the cytocentrifugation. This is the assembly which consists of a cytocentrifuge funnel. There is a filter card and there is a slide. And this is the schematic diagram, and a daily disinfection of all these working surfaces are necessary, and a calibration of the machine is also necessary to get a consistent results. Now coming to the assembly, that is a centrifuge assembly, you have to take the centrifuge clip, cytocentrifuge clip, and put the slide into the clip, followed by the filter card, followed by the funnel. And once the assembly is tightened, go to the centrifuge bowl and put the assembly in opposite directions, and charge the sample with 2 to 3 drops of last part of the centrifuge sample. 2 to 3 drops are taken from the lowermost portion of the centrifuge tube, and equal drops are put on opposite side, so that it has to be balanced. And the spinning is, once it is done, then close the chamber and spin at 1 minute, spin at 2000 RPM for 1 minute. Now at the end of 1 minute run, unscrew the assembly, slowly take out the slide with the filter card out, and on the opposite side of the, keeping the filter card along with the slide on the opposite side. This is the smear side, and opposite side of the smear, just mark the smear area using a diamond pencil, and immediately put it to the fixating. And after fixing, the smear will look like this. You can see a small 6 millimeter round smear which is unstained, and after staining it will look like this. This is the cover slip smear, and this will end up in a thin monolayer in a limited area, and care has to be given to avoid air drying, and immediate fixing is necessary before air drying. Then coming to the saline rehydration technique for the hemolysis, the principle is that the physical damage caused by air drying to RBC is more than the damage caused to epithelial cells and other cells. So the rehydration with the saline leads to the rupture of RBC, but to preserve the epithelial cells and other cells. So this is a very easy technique. What we have to do is, like usual way, make an extra smear, air dried smear. That is a smear, hemorrhagic smear. You can see the hemorrhagic smear, and the smear is prepared and it is air dried for 5 minutes, either in an incubator at 37 degrees Celsius. And if you don't have an incubator, simply keep it outside for 5 minutes on the room temperature, so the slide will be air dried. But the second step is placing the smear on a staining bar on an horizontal way. You have to keep it on a staining bar, and after that, slowly put a saline from one corner of the smear on the smear, and completely flush the slide with the normal saline. Normal saline is put into that, and flood with the normal saline for 30 seconds. You have to keep the saline for 30 seconds. Slowly put the saline so that the smear will not be disrupted. If you are putting very forcefully, the smear can be disrupted. And once after the 30 seconds is over, you can see the hemolysis is taking place, and take out the smear and blot it, just holding on a vertical position. Then put it into the fixative. So this is a simple technique. This is the picture which will show you. This is a hemorrhagic smear after saline rehydration. All the RBCs have been lysed, and even with a clean background, the screening and interpretation becomes easier. What are the factors for optimal results for saline rehydration? Drying can be done up to 30 minutes. If you are drying instead of 5 minutes, it can go to up to 5 minutes, 10 minutes, or even up to 30 minutes, nothing will happen. Optimal time is 5 minutes. Mucoid samples may require more time because it is a sticky material. Nuclear blurring may occur if the slides are kept more than 5 minutes in saline. So we have to restrict the time in saline. So usually we give saline rehydration for 30 seconds. So we should not keep more than 30 seconds. And 30 seconds is optimal for cleaning the background of serous fluids, and mucoid samples require more than up to 1 minute. And if the incubator is not available, room temperature can be used for drying. What are the advantages? It is simple, inexpensive, cost effective, less distracting background, because while screening, we will get a background which is clean, no fear of air drying while making the smears, better cell adherence, not time consuming, clean background, good for taking micro photographs. What are the disadvantages? Cellular blurring, if more than 5 minutes are given for saline rehydration. Degenerated samples, suppose the sample is already degenerated. If you are subjecting it to further trauma, it will become more degenerated and the smear morphology can look very degenerated. Lymphoid and non-epithelial cells can get a distorted morphology by this technique. Now coming to the sputum sample is collected in Petri dish in Sata Hospital, and these are the sputum samples. The patient is given the Petri dish to collect the sputum sample. Once the sputum is collected, it is examined for the adequacy in the lab. So we are using, we have to use a strong source of light to check the adequacy, and the sample is thoroughly checked for the presence of black, white, and we have to also use a white background as well as a black background. This can be a black paper or a white paper, and a Petri plate, it is transparent Petri plate has to be kept on the black and white background. Now the sample is thoroughly examined for the presence of white opaque areas or blood tinged areas or black spots. And these spots or one of these areas are representing, indicating that the smear is representative. Suppose such areas are not present and the sample is consisting of only frothy saliva, the sample should be rejected. Now, what is the difference between saliva and sputum? Saliva means it contains no diagnostic cells or no diagnostic value. It contains only squamous cells from the buccal mucosa, whereas sputum contains samples from various samples from cellular material from the respiratory tract, and it is very important. Now, there are 3 methods to make the smear samples from the sputum, either pick and smear method, Sacco-Mano method, or liquid-based cytology. I will be discussing the pick and smear method, which is a simple and a cost-effective method. So what you have to do, you have to use a light source and observe the representative material from the sample, and using a sharp stick, you have to slowly pick the material onto a glass slide. And this is the material, blood tinged areas picked up on the glass slide, and using the sharp stick, slowly spread the material over the smear and slowly spread, and care has to be taken. The material is not getting air dried during the preparation. And once the smear is prepared by spreading, this is known as pick and smear. The sample is picked and smeared with the use of a sharp stick. And once the smear is spread, it is put into the fixative bottle or with fixative. And if this is not, if the material is very tenacious or rubbery, we can crush between 2 smears and then use the sharp stick to spread the material. Now you can see that this is a saliva, only saliva material, where you can appreciate only squamous cells and WBCs, where this is a very good, adequately prepared smear where we can see many pulmonary macrophages. Now, what is the importance of pick and smear method? What are the disadvantages? It's a limited sample and it is a very tedious because of the thick contained areas. It is tedious for screening. Now, the second method is Sacco-Mano method. It is a pooled sample method, and sample is collected in 2% carbo bags with a 50% ethanol. That is the Sacco-Mano fixative, and the specimen is blended and centrifuged, and from the deposit smears are prepared. It is very tedious and cumbersome procedure, and because of the blending or vortexing, what happens? We'll get a distorted architecture, clusters will break, and diagnosis will be difficult in small cell carcinoma and adenocarcinoma, and smears are more. But the more advantages is that, since it is a representative of multiple samples, smears can be more representative. Now, what are other important points? Immediate processing and fixation is necessary to avoid air drying and degeneration. So you can see this smear. This smear is showing air drying artifacts, and you can see this nuclear chromatin is blurred or smudged. We cannot make any diagnosis out of that. Coming to this smear, you can see the degenerative chromatin. Again, it is difficult whether it's a normal cell or an abnormal cell, because the chromatin is degenerated. It becomes difficult. We are appreciating this kind of a smear where the chromatin is very crisp and the details can be readily appreciated, and the diagnosis can be readily done. Now, coming to the other smears, that is vagina cervix and the FNSE, from vaginocervical smears, FNSE smears, and brushing smears from the various scopy material. These are collected at the time of examination or scopy, and it is immediately fixed in fixed cytology fixative, and it is directly subjected to staining. FNSE smears are stained by both Papanicolaou and MGG staining. So does the fluid smears that is also stained by both Pacnicolor stain and MGG stain. Coming to the gynecological smears, these smears are collected with the help of one of the devices, either broom brush or air spatula or a cotton tipped applicator stick. In Tata Memorial Hospital, we are using sterilized cotton tipped applicator sticks. These are very cost effective and thin. We can prepare. It can be in-house prepared. And these are the best collecting devices according to our study, and it is non-traumatic, inexpensive, and easily available. Whereas what we have noticed with air spatula and a lot of air drying artifact, and this broom brush is costly. Now coming to oral smears in Tata Hospital, we are collecting with it can be either collected with a ice cream spatula, wooden spatula, or with a toothbrush. We prefer toothbrush because it can sample a lot of material from the oral cavity. First of all, we have to expose the lesional area using the index finger and the thumb finger. The lesional area is exposed with a light source, and the toothbrush is moistened with the saline. 1 or 2 drops of saline is put on the toothbrush, and using the toothbrush, it is the area is brushed to and fro in a to and fro motion till a pinpoint bleeding occurs at the lesional site. Once the pinpoint bleeding is coming, stop the brushing and tap the brush on a pre-albumination. Just tap 2-3 times. You can see white speckles appear on the smear, and this is immediately fixed into the fixative bottle. This is the way we do. This is the collection of oral smears. Now, along with the smear collection, we also supposed to collect the clinical data, which include age and gender of the patient, clinical symptoms, other habits, tobacco habits, etc., imaging findings, copy findings, previous histopathology diagnosis, previous treatment, surgery, radiotherapy, chemotherapy, etc. These all are required for making a proper cytological diagnosis. Now coming to the next step, that is staining. Accurate staining is the most important prerequisite for appropriate patient management. This involves correct identification and characterization of cells, tissues, and various etiological agents involving different disease processes. For microscopic examination of the cells, the smear should be thin enough to transmit the light, adequately fixed, and optimally stained. It is a well-known fact that the staining performance varies with various laboratories depending upon their protocols and methodologies. For optimal staining quality, proper fixation of the smear is one of the most important factors. Now, coming to the fixation, I'm not going to the definition of fixation. My colleague, former Dr. Ujjwala Joshi has already explained you the various steps in fixation. Anyway, an ideal fixative should stop the bacterial decomposition, autolysis, and should keep the tissue without damaging the cellular morphology. Fixative should not distort the cellular constituents by swelling or shrinkage, and should withstand the subsequent chemical used in the processing, and also should be cost-effective, non-toxic, and non-flammable. What are the factors affecting fixation? Buffer and pH, temperature, penetration capacity of the fixative, volume change, agitation, osmolality of the fixative, concentration of the fixative, and the duration of fixation. Now, the cytological fixatives are classified into wet fixatives and dry fixatives. Coming to the wet fixative, an ideal fixative for cytological specimen is ideal fixative. The best fixative for cytological specimen is equal volume of 95% ethanol and ether, that is 1:1 ratio. Now, many laboratories are stopped using ether because of its hazards. It poses several hazards, including flammable nature, pungent smell, and hygroscopic effects. And instead of ether and ethanol mixture, many laboratories are using nowadays 95% ethanol only. This is a very good substitute, and it's a very good fixative for cytology. And in many places, 100% methanol is used as a fixative. We are using 100% methanol with very good results. This is especially useful, a substitute, especially when there is non-availability of alcohol, that is ethyl alcohol, and shortage of ethanol. And other fixatives, less used cytological fixatives include 80% isopropanol, propanol, denatured alcohol, etc. Now, what are the factors affecting fixation? Smear should be fixed immediately. The fixative solution, as even the slightest air drying, can alter the cytomorphology, causing the diagnostic problem. Smear should remain in the fixative at least 20 to 30 minutes to assure adequate fixation. Prolonged fixation for several days will not alter the morphology. And in such a case, a fixative bottle can be kept in the fridge to reduce the evaporation. Thin monolar smears are easy to fix. and easy to cover slip and screen, whereas thick smears prevent rapid penetration of the fixative, as well as the staining will be difficult and screening will be difficult. And we should use 100% pure ethanol, 100% of pure ethanol, or if it is impure ethanol, it has to be distilled before using for preparation of fixative as well as for the staining solution. Now, what is the other fixative? No, dry fixative, or it is the dry fixation. Dry or coating fixatives are major substitute for wet fixative, especially for cancer detection camps or for the transportation of the smears from the distant collection centers. These fixatives are available commercially under either aerosol, this is applied by spraying, or a liquid base where it is a solution which we can drop the solution, put drops on the smear. They are composed of an alcohol base which fixes the cells and a wax-like substance that forms a thin protective coating over the cells. Some ordinary hairsprays can be substituted as coating fixative. However, this has to be tested before using on the smears. Now, how we will use it? Smear is prepared on the usual way, and once the smear is prepared, just spray the fixative, apply the spray on the bottle, and at least 8 to 10 inches away the fixative has to be sprayed. Otherwise, it will cause artifacts by layering holes on the smears. So we have to be very careful while spraying. Or the coating fixative can be dropped. It has to be removed from the smear prior to staining. For this, see, this coating fixative will form a layer. This has to be removed for pap staining, before pap staining. This is done by dipping the smears in 80% ethyl alcohol. Sometimes 2 changes of 80% alcohol may be required. Suppose it is not removed completely, the smear has to be checked every now and then, or it may be checked at the end of 24 hours. You can see the bubble appearance on the smear. If that bubble appearance shows that the wax is not removed completely, it may require more soaking in the ethanol. Now, coming to the Papinicolo stain, pap staining has been used all over the world more than half a century for the staining of cytology smears. Without Papinicolo staining, there is no cytology smears, or there is no cytology. Pap staining results in well-stained nuclear chromatin, differential cytoplasmic counter staining, and transparency. Many modifications have been published after George Papinicolo, an American of Greek descent, who has described the original staining way back in 1942. Staining performance varies with various staining protocols and methodologies, and every laboratory has to standardize their own protocols. What is the principle of pap staining? Papinicolo staining is a polychrome counterstain method based on dye competition in the cytoplasm combined with a nuclear hematoxylin staining. It consists of nuclear stain hematoxylin and a cytoplasmic stain. There are 2, OG6 and EA36. And before that, I will just give a mention of color index number. Specific color index number. The number is given to refer a given stain that has been certified Biological Stain Commission. This is important that names of the dyes vary from region to region and country to country. For this reason, they have been catalogued by a particular digit number that is unequivocally identifies the dye. And every dye bottle, if you are purchasing, it will show the total dye content, that is TDC. It refers to the purity of the dye. TDC varies from batch to batch, and the actual dye content or the dye concentration required for the stain preparation can be calculated by grams of the dye required for new batch is equal to actual dye required divided by concentration of the new batch. This is the formula by which we can calculate. Now, coming to the hematoxylin, this is the first nuclear stain used in Papinicolo stain. Hematoxylin is the most widely used nuclear stain. It is commercially available in an amorphous brown form, and it is extracted from the Central American log food, that is Hematoxylon cambaceanum. And hematoxylin itself is not a dye. It has to be oxidized to the staining component, that is hematin, which can be either takes place ripening, and hematoxylin oxidation can take place either naturally by keeping over a period of time, or it can be achieved almost instantaneously by addition of oxidizing agents such as sodium iodide or mercuric oxide. Hematoxylin can stain DNA, RNA, nucleoproteins, and mucus. It will be stained with a purple color, and it can be used as a progressive stain or a regressive stain. Ms. Ujjwala Joshi has already described you what is progressive stain and regressive stain, and it has to be blue. The second step is bluing, and where the absorption peak of hematoxylin shifted, and it results in visually resulting a change of color from pink to bluish purple. There are various types of hematoxylins. Harris, Gills, Meyers, Wagers are the most commonly employed hematoxylin. In TMH cytology laboratory, we are using Gills hematoxylin followed by bluing in Scott tap water substitute, And this has been practiced with very good results. Remember, stains can be either used as ready-made stains, which are readily purchasable, or it can be in-house preparation. We prefer in-house preparation because we have a control over the constituents and quality. And Gills imetoxylin, this is the preparation of Gills imetoxylin. 2 gram percentage of 0.2 gram percentage of imetoxylin is prepared in distilled water, ethylene glycol. Ethylene glycol is the solvent, sodium iodide is the oxidizing agent, aluminum sulfate is the mordant, and glacial acetic acid is added. Then Gills imetoxylin can be prepared easily and rapidly. The unoxidized imetoxylin can form a metallic scum on the surface, and which has to be filtered every day. And although this has to be filtered with the Waterman #1 filter paper, and fresh imetoxylin has to be added whenever the level of the staining jar is dropping down or if it is low. When used as a progressive stain, Gills imetoxylin stains the nucleus to the desired intensity, and this is followed by bluing. The optimum nuclear staining time with the imetoxylin, Gills imetoxylin, is 1 minute to 1.5 minutes. Now coming to the second stain, cytoplasmic stain, OG6. OG6 is an acid protein dye which can compete with the other protein dyes. OG stains with the cytoplasmic keratin. It is only for keratin, and it stains keratin as a brilliant orange, yellow, brown color. And usually parakeratotic squamous cells, HPV infected cells, well-differentiated squamous carcinoma cells, hemosiderin pigment crystals, and asbestos bodies stain with the OG6. The preparation of OG6, usually 0.5% of the OG6 solution is prepared. OG6 powder, phosphotexic acid, distilled water. Usually OG6 has to be dissolved in distilled water first, followed by constitution into 1000 ml using the remaining ethanol. Now OG6 is stored in amber colored bottle and in the refrigerator because it is a light sensitive stain which can degrade on keeping with the bright light. And phosphotexic acid maintains the acid pH of the sample. Acid pH of the stain. And being it is a supersaturated solution, and it should not be filtered, and it should be kept like that, and the crystals will be formed there. It has to be gently stirred before staining with a glass rod. Before staining, glass rod has to be used to mix the stain solution so that the stain solution will be uniform. The stain can be replenished daily to maintain the satisfactory results. Usually after staining about 2000 slides, the useless stain can be discarded and replaced with a fresh stock solution. Coming to the next slide, that is EA36. EA stands for eosin azure. It is a polychrome stain containing 3 ingredients. And these are 3 stains, that is eosin yellow, light green SF, and Bismarck brown. These 3 stains has to be prepared separately as stock solution, and then it has to be reconstituted. And along with these stains, we also have need phosphotexic acid and lithium carbonate solution. This can be readily purchased, or we have to make it in-house. In Tata Hospital, we are making in-house. Now, these are the stock solutions of lithium carbonate, Bismarck brown. All solution has to be prepared separately, and the formula is 2.5 gram in 500 ml of 25 ml of water, followed by 4 to 75 ml of 100% ethanol, and all are in a 0.5 gram percent. Then to making for 1 liter of EA36, we have to add equal 450 eosin yellow and light green, followed by Bismarck brown 100 ml and 2 grams of phosphotexic acid. So this is the preparation. After staining 200 slides, 2000 slides, the stain solution can be replenished with the new, and this is we have to check daily what is the staining quality. Accordingly, the staining solution can be substituted or replenished with the new. Now, coming to bluing, aluminum aqueous, bluing is an important procedure after nuclear staining. Aluminum aqueous solution tends to dissociate. Aluminum combines with hydroxyl ions from water to form insoluble aluminum hydroxyl ions. And free hydrogen ions from water tends to form high sulfuric acid by combining with the sulfate from alum. If excess of acid is present, aluminum hydroxide cannot be formed due to lack of OH ions. So, hence, acid solutions of aluminum hematoxylins are red in color, whereas aluminum-like hematoxylins are blue in color. So we need aluminum-like hematoxylin, and which is the blue helps to neutralize the hydrogen ions and makes available free OH groups for the formation of aluminum hydroxide. So bluing is an important step. Otherwise, the purple color of the nuclear chromatin cannot be appreciated. It will look blurred or it will look pinkish. All formulae of hematoxylins are with or without addition of glacial acetic acid. So we have to adjust. Bluing should be done with a high alkaline solution, usually with a pH of 8 to 8.5. So there are various bluing agents. Scott water substitute is the one which we are using. These are the ingredients. We have to use magnesium sulfate and magnesium bicarbonate in 1 liter of distilled water, or other bluing agents include ammonia water, that is 3% of ammonia in 70% of ethyl alcohol, or lithium carbonate solution, dilute solution. So this is the PAP staining protocol used at Tata Memorial Hospital. Every department, every laboratory has their own protocols. You have to standardize your own protocols. What we do, this is our protocol: 10 dips of 10% is 10 dips of 95% ethyl alcohol, followed by 10 dips of 50% alcohol, distilled water, followed by gill simethicillin for 1 minute, followed by distilled water rinse, 2 rinses, 2 changes, then thorough rinsing, 2 changes, then Scott tap water substitute, the blowing agent. Blowing agent is for 1 minute, followed by 10 dips in tap water, 1 change, followed by 75, 95% ethyl alcohol, 10 dips each, 2 changes. Then orange G, 1 to 1.5 minute. This will, this is the first cytoplasmic stain. Then 2 dips, 2 quick dips, one dip in 95% ethyl alcohol, which will remove excess OG. Then go to the second cytoplasmic stain, EA36, again 1.5 to 2 minutes. Then immediately, then slowly remove the 95% excess OG by dipping in 95% ethyl alcohol, 2 changes. Then dehydration in absolute alcohol, 2 changes. Then alcohol xylene, 1:1 mixture, 1 change, followed by clearing in xylene, followed by 30 minutes clearing, then mounting. Now, staining can be either done manually when the workload is very low. That is usually the workload per slide output. Output is less than 100 slides per day. We can use manual staining, or if it is more than 100 slides, it is recommended to use a auto stainer. You can use any company's auto stainer. You can adjust auto stainer processing according to your requirement or your protocol or SOP. And what is the advantage of the disadvantage of manual staining is the subjective variation, because different people will do the different way. There may be slight variation in quality in manual staining, whereas automatic staining can cause no subjective variation in quality. And advantages is bulk slides can be stained, consistency of the quality, and less manpower is required. And disadvantage is more reagent is required, grades are spoiled frequently, there is no blotting in between. Now, results coming to the particular result: nucleochromatogen is classical blue to purple, RNA-associated DNA is delicately stained, and nucleoli will display eosinophilia. Bar bodies are conspicuously stained, mucus and cell debris are minimally stained, thereby show unobscure in background. OG6 stains keratin, brilliant orange in color, whereas the second counter stain, EA30, stains cytoplasm various shades of pink in eosinophilic cells, or pale blue or green in deeper cyanophilic cells. Now, these are the stains. You can see eosinophilia, cyanophilia. These are the glandular cells, orangophilia, keratin, and the metaplastic cells, deep cyanophilia. You can also see cilia in bronchial epithelial cells, adenocarcinoma cells. Chromatin can be seen. Reddish nucleoli can be appreciated. Again, cyanophilia. These are carcinoma cells, orangophilia, and the mesothelial cells showing dense cytoplasm. All this panorama of colors can be appreciated with the. Then coming to validation, as soon as any stains or staining solutions are prepared, it is important to validate the quality of the prepared stain solution. For this, few extra smears have to be prepared from the stored sample. Whenever new solution is prepared, test round of staining is performed to check the quality of the prepared solution. Any deviation is observed. Accordingly, corrective action and preventive measures are done. In addition, every day before starting the staining rounds, a test round of staining is done, and this is to ensure the staining quality of the staining machine as well as the staining setup. Now, important factors for staining for optimum results. Excellence of PAP staining depends on a lot of factors. The quality of staining is dependent on staining time, solubility, percentage of dye concentration, and the nuclear and cytoplasmic stains. Smears should not be allowed to dry in any time. Prolonged staining of stain smears, keeping of the stain smears in final grades of alcohol should be avoided, because it will show destaining of the staining, and stains are kept well covered with the water so that water absorption can cause dense opaque stain. And daily filtration of alcohol grades through tight wad of cotton is recommended. Removes free floating cells and cross contamination, and care should be taken to mix the grades with while filtering them. All staining solution, after approximately 2000 slides, the alcohol grades and grades can be filtered through Wadman number 1 filter paper, and we have to check the pH of the ethanol. Usually we can use a pH meter. The ideal pH is 7. This is the filtration of the sequence of filtration, just to show that there won't be any mix-up between 2 solutions or 2 grades. Now, daily filtration of hematocillin is recommended through Wartman number 1 filter paper. Use of coating fixative has to be removed, and a daily filtration of xylene through Wartman number 1 filter paper to remove the moisture and flow test is advised. So Scota water substitute has to be fresh, or after each round of staining, it has to be checked, and the pH of the Scota water has to be checked. It has to be always above 8.1, and the change of water rinses after each round of staining is necessary. Absolute alcohol and xylene has to be the last has to be fresh in the last step. To achieve the complete dehydration. All the dehydration of alcohol, creatine, and xylene should be replaced. And otherwise, if you are not noticing pale murky stain or loss of sharp contrast. Now, when manual staining is done, it is a good practice to blot the slide carriers on a little pile of blotting paper for a few seconds, so that it will save the next staining solution, and it will not be contaminated. Commercially available ethanol is generally not reagent quality, so it has to be either redistilled, or we have to ensure that 100% certified pure alcohol is obtained for grade preparation and stain preparation. The life expectancy of the stains may be increased by storing them in dark bottles, or if it is not in the use, we have to keep it in the refrigerator. And OG6 and E36 are supersaturated, so should not be filtered. If you are filtering OG6, it will result in dilution, and finally, it will affect the quality. pH of the stain have to be monitored. Coming to the pH, the staining depends a lot on the pH. Here you can see this is an ideal pH of the nuclear stain hematocillin. The ideal pH has to be 3, that is an acidic pH. If the pH goes down to 2, the staining appears like this. If the pH goes above, that is above 3, that is the staining appears like this. If the pH is again brought back to the normal pH, that is 3, you can see the same smears are looking like a very beautifully stained. So pH plays an important thing. Here also you can see ideal pH for OG6 is like this. OG6 stains very beautifully with the 4.5. If it is more than 4.5, it is pale. And in less than 4.5, again it is inhomogeneously stained. But at the 4.5, again bringing back by adding alcohol or alkali, you can just acid or alkali, you can bring back the pH to the original pH. Again the color restores. Again the ideal pH of E36 is 4.5. Now we can do destaining and restaining if the smears are not stained satisfactorily. So this has been done by removing the cover slip. For that, we have to mark with a diamond pencil the upper lower edges of the cover slip, and keep the cover slip and the slide along with the slide in a xylene solution, so that till the cover slip soaks. You have to keep 24 hours sometimes, so the DPX is dissolved and the cover slip will be fallen into this thing. Once the cover slip is fallen, smears are transferred into a jar containing 95% ethanol for sufficiently long time, preferably 1 to 2 hours. And the smears are then placed in 1% acid alcohol for decolorization. This may require a few dips or maybe more longer to 1 minute or something. And acid alcohol can be, and this will decolorize the smear. Acid alcohol can be prepared by adding 1 ml of sodium. This is 1 ml of hydrochloric acid concentrated to 99 ml of 70% ethyl alcohol. And the slides are generally thoroughly washed after acid alcohol treatment. Then once it is washed, it is then placed in the fresh staining ground for further Papanicolaou staining. And the MGG staining, this is the second staining used in cytology. This is a complementary staining. Papanicolaou staining is must along with the MGG staining. And this is a 2-step staining. And we have to treat it with MGG stain for 20 minutes, followed by Giemsa stain. Now, these are the results of the MGG stain. I'm not going to the details of the MGG stain. It will give the various colors of purple and violet colors for staining version. This is the pinkish color. This is the Papanicolaou stain showing mucin pink, and this is the MGG stain. And this is the Papanicolaou stain showing keratin and all. This is the MGG stain. How it will be looking like a sky blue color for the keratin. And this is the metachromasia in MGG stain. This is the adenoid cystic carcinoma, where the basal lamina material is showing the metachromatic stuff or the bright reddish color. So this is again in a Papanicolaou stain. This is the stroma in DSRCT. This is the Burkitt lymphoma in Pap smear, and this is the vacuoles and cytoplasm very clearly seen in Giemsa. So all hematolymphoid malignancies require treatment with MGG or the Giemsa stain, migrant wall Giemsa stain. Now I'll go to the just describe this. Coming to the mounting, smears have to be mounted under cover slips to maintain the eye refractive index. It is necessary for microscopy as well as to preserve the smears for long storage. Cytology smears have to be storage as per the accreditation agency minimum 5 years. And there are 2 types of mounting media used for aqueous or resinous. If it is mounted with aqueous media, we cannot store it permanently. This is only for short time, just for a simple, 1 minute, 10 minutes or something, not more than that. And for long-term storage, resinous mounting media is preferred. Aqueous mounting media is used in some enzyme histochemical methods and for ROS, rapid onset evaluation, and etc. Resinous mounting media are used for routine staining technique where the CSR sections are mounted from silane. Now there are various aqueous mounting media such as gelatin media, gum arabic media, glycerin jelly, and Apodis media, or fructose syrup. Whereas resinous mounting media includes, it can be either natural resinous material or synthetic resin. Now, Canada balsam and Dummer balsam or colophonium resins and terpenes resins are examples of natural resinous mounting media, whereas the most common example of synthetic resinous mounting media is DPX, that is the Kirkpatrick Landrum's DPX, that is Western is the plasticizer, xylene is the dissolving agent, and it also contains dibutyl phthalate, that is the plasticizer, and xylene is the solvent. Now, Canada balsam can be obtained from the Canadian fig tree. So for cytologists, yes, Canada balsam is preferred because it's a neutral Canada balsam. It maintains the color of the smears for a long time. This is the tree, Canadian fig tree, which is known as Abies balsamea, and from the tree, it can be from the leaves and the tree tips it is obtained, and if I can skip. Now, coming to the FNAC, where we can do ROS, rapid on-site evaluation, for measuring, for checking the sample adequacy. This is an important step for the collection of cytology, because nowadays cytotechnologists or cytotechnicians are supposed to go for the sample adequacy check along with the pathologist for the sample adequacy. It gives a proper site. It will avoid a representative. It will ensure sample collection is from the proper site, representative smears, adequate in quality and quantity. So what are we supposed to do? So rapid on-site evaluation of sample adequacy of FNA is important procedure to ensure the adequate cellularity of the lesional cells in the same sitting at the time of FNA procedure. It will improve the rate of representative aspirate and minimize the repeat procedures, and extra samples can be collected for ancillary tests of triaging. Besides adequacy, effective in rendering rapid diagnosis at ICU or urgent cases, and it is time-saving, cost-saving, as well as the actual cost of the test is just 5 rupees per slide. So what are the tests? FNAC is performed by the pathologist or radiologist. Then smear has to be fixed immediately in either ethyl alcohol solution for 30 seconds. Then stain with the smear is then stained with 1% toluene blue for 10 seconds. Then just wash in water 1 dip or 2 dip. Then just mount the slide with the glycerin. Then check the cellularity, wipe the slide excess glycerin and all. Then check the cellularity under the microscope. And either this can be done by a pathologist or a trained cytotechnologist. If the cellularity is inadequate or if the cells are not representative of the anatomical site, it has to be reaspirated in the same sitting, or then again it is to be adequate. Then it can go for final staining with a pap staining. And we can also collect extra. This is a very simple 1-minute procedure. It can be done, but it has to be validated at every center, and it has to be performed at the FNAC clinics. Now these are the setup record, and this is how the toluene blue stained smear look like. Now coming to the cell block, cell blocks are essential part of. Kedar sir, how long I can go? Hello.
Salim, I think time will you take? We can take about 4 or 5 minutes more.
Okay, sir. I will clear cell block and I will finish. Okay.
Yeah,
just
okay.
one method.
Cell block,
so cell block is an important procedure in a cytology laboratory. The principle is salvaging residual sample, concentrating the cells and embedding the cells in an appropriate medium. And the advantages of the cell block is that we can cut multiple sections from the same cell block, and it will be available even after the sample is discarded. Cell block can be stored for long years for research, diagnosis, molecular test, etc. It is useful for IHC and for differentiation of reactive mesothelial from mesothelioma and adenocarcinoma. It is also useful for elucidation of occult primary site of malignancy, characterization of lymphoproliferative disorders and undifferentiated, poorly differentiated malignancies, for prognostication, ancillary tests, and molecular tests. So there are various methods: direct method, agar method, thromboplastin plasma method, scrap cell block method, and automatic. I will go for not only for thromboplastin method, plasma thromboplastin method, which is practiced at Tata Memorial Hospital. So I will skip this. I will go for the plasma thromboplastin method. The approximate cost of the method is just 50 rupees. This method is very good when the amount of the cellular sediment is less than 0.5 ml. So what you have to do, first you have to centrifuge and remove the supernatant into a test tube and separate the sediment. You can see the sediment. And into the sediment, we have to add pooled plasma, 3 drops, followed by 3 drops of the, or 2 drops, either two drops of the pooled plasma, followed by 2 drops of the thromboplastin. Just mix the solution, keep it for 5 minutes. At the end of the 5 minutes, a clot will be formed at the tip of the, at the end in the test tube, and just tapping the test tube, the clot will fall onto a small piece of filter paper. This filter paper can be folded and put it into the tissue cassette, and it can be fixed in 10% neutral buffered formaldehyde. Now, this is a very easy technique, and this gives excellent results. Everybody should follow. We recommend this technique is to be followed. This is cell block is a very important diagnostic material. So it has to be prepared in most of the excess samples, which are left out samples. Now, this is the sections, cell block sections, and this is the HE section. Usually 5 micron sections are cut, and how HE stained smear look like after cell block sections are cut and stained. Now, cell block sections can also be automated. Celient is another is a machine, or Shandon is another machine which gives sections automatically. Now, I will skip this. Samples can be stored for 20 to 48 hours, and it can be discarded. And washing with the 1% sodium hypochlorite is essential for cleaning. And to conclude, we have to segregate the waste also. This is also a requirement. I think most of the laboratories are following this. And in conclusion, I have to tell, careful and proper processing and staining leads to optimal smear quality. So we have to apply QC and QA, and it needs to be maintained throughout the processing and staining, and even the other phases of the smear for reporting and all. Continuous monitoring of quality is a must. You have to have a dedicated quality monitor for a person, quality manager for this. Identification of deviation and immediate corrective action, or even checking whether the corrective actions are occurring, or preventive measures. All these things have to be done. So quality is maintained. And technologists or technicians need irregular training. Now, they have to be trained in a 6-monthly basis or something for the smear preparation and staining, and they have to be given the chances of presentations as well as little projects and validation procedures, etc. And technicians also, technologists also should be part of quality control system, so they know how a smear look like, how a smear can deviate, and they should not be just simply making smears and not knowing what is the other end of the coin, what is happening. So this is my last note to say. And with this, I want to tell this, this book is available for purchase. If anybody wants, they can contact at this email address. All the nitty-gritties and techniques in cytology. This is published from Tata Memorial Hospital. I just described whatever the techniques which we have described in this book only. It is available for purchase. The cost is 1,000 rupees. Now, thank you so much for your patient hearing. I know it was a very lengthy lecture. I was trying to cover up everything, and the session is open. I am ready for any questions. Over to Dr. Kedar.
Salim, thank you so much. I think good that you have given your email address here, because there are multiple questions. I will try to combine those questions and maybe I'll take liberty to ask you for 5 to 7 minutes. These.
Yes, sir. Yes, sir.
The good thing that you did is that you mentioned email, because some people may have questions about how to purchase the book.
Yes, sir.
Actually, the questions were more on the staining aspect.
Okay.
So, the earlier question was function of EA36 in Pap staining, and what is the substitute for OG6?
What is that? Sorry?
Substitute for OG6.
First, I will answer the first question, the function of EA36.
Yes.
EA36 is used mainly for staining the cytoplasm. It is one of the cytoplasmic stains. And in the cytoplasmic stain, cytoplasm can be an immature cytoplasm, or a mature cytoplasm, or a maturing cytoplasm. Depending upon the various grades of maturation in the cytoplasm, it will give a differential staining. It can give a pale cyanophilia, indent cyanophilia, or eosinophilia, or dark eosinophilia, something like that. So eosinophilia is the maximum end of the EA36. So it will start with pale eosinophilia, dark eosinophilia for immature cells. Then mature cells, on maturation, it will be more eosinophilic. So this is the differentiation of on the basis of cytoplasmic staining. We can differentiate whether it's a mature cell or an immature cell. Then coming to the keratin, there is cytokeratin stain, that is OG6, that is principally used for demonstration of the keratin, whether there is keratin is present and in how much amount, whether it is hyperkeratotic or whether it is normal keratin. All cells, all squamous cells or even glandular cells may contain certain amount of keratin, but this can be appreciated in quantity wise looking at the staining quality, whether it is very bright orange or clear node. So keratin stain is done by, even if you are removing keratin stain, pap smears can also work with only E36. It is not necessary you have to have a OG6. But if it is OG6 is there, it is always give you the amount of keratinization as a additional benefit. Now, I don't know what is the other substitute for OG6. OG6, which I haven't used in Tata Hospital, nor I am aware of this. But without OG6, you can run the pap stain.
Okay.
Only A36.
How do you maintain pH of OG6 and EA36 solutions?
See, this is, for a long time we were not doing this. Of late, we understood that, these are all costly solutions, stain solution. We cannot throw it very frequently, just because staining results are not coming properly. No, when something happens with the staining, we have to do a root cause analysis. What is the reason? Whether it is stain problem, whether it is alcohol problem, whether it is DPX problem, whether it is smear problem, fixative problem, we have to sort out what is the exact. Everything need not be a reason from staining, something like that. So we have to have quality pictures or quality boards in front of you. This has to be the pH of the, this has to be the level of the stain solution. This is the, ideal pH of EA36. This has to be charted, or this is a constant value. So this value has been discovered after a lot of research. We found that this is the ideal value. Nowhere in the textbook they have mentioned what is the ideal value. So we did every day, we check. Every day the better staining comes, we will note the, this is the pH of today. So we identified from the chart, which is the best pH, gives the best result for EA36 and OG6 and, hematocillin. This has been charted. And once in a, whenever we prepare, we check the pH of the solution. When we replenish, again, we will check the pH of the solution. When we get an alteration in the staining results, we will check the pH of the solution. And if there is a long delay in staining is not done, so stains are kept in the refrigerator and brought back, again, we will check the pH of the solution. And it will be, suppose it is altered, we will bring back either using one normal hydrochloric acid or, dilute sodium hydroxide solution, and it will give the proper results. Like it has to give, if that is the only reason. If it is the only reason.
So trial and error will take a long time.
But let me tell you.
Spend a lot of time.
See, these are already documented in the books and all. So what they can do, you have to have a pH meter. You have to have a pH meter. The investment is just 15,000 rupees. Anybody can get a pH meter, 15,000. It's a very small, it's not a big amount of equipment. So you can check the pH of any solution, but pH plays an important role in everything.
Everything, yeah. The other question is, how long a smear can be left in fixative before staining?
It can be kept many days, weeks, months, or anything. Suppose we want to use, we are supposed to use this smear after accumulating some another 15-20 smears, or maybe it is a campsite, they have to transport it after 1 month or something. So it has to be collected in fixative. There are two ways. Either you can you collect it after fixing with a hairspray or dry fixative, or you can collect it in the wet fixative and put the lid of the fixative bottle tight, and you can seal the fixative taken with a parafilm or something and keep it in the refrigerator. So evaporation will not take place. And the day it is transported, it has to be taken from the fridge. But if you are keeping long time in the fixative, nothing will happen. It will remain as such. It is a recommended method.
Okay, Salim, can we destain a slide and restain it with a different stain?
Different stain like what? Suppose, it is pap stain is a fixed smear. Pap stain is prepared as, pap stain is done on a wet fixed smear. Okay.
Yes.
So any stain which is using a fixed smear can be done after destain. Suppose you are using the pap stain smear, destaining that, and this smear can be used for example, you want to do fungus stain, where we are using fixed smear, GMS. You can use destained pap smear if you are using, but you cannot use de-stained pap smear for MGG. Because
Okay.
MGG, GIMSA is done on a air-dried smear. First
Right.
air-dried, followed by fixation. So if
Correct.
you're using pap smear, de-staining and applying MGG, it will not work out. It will not give you the proper result. Because
Okay.
MGG is based on air drying artifacts. And
Okay.
same thing, Dr. Kedar, I want to add a note in that. Same thing, if it is a GIMSA stain smear, after destaining, you cannot do PAP because we have
Okay.
already introduced air drying artifacts.
Okay.
Because PAP
Okay.
staining is done to avoid air drying artifacts, It
Yeah.
has to be in the listing. Both ways, it is not possible.
Yeah, Salim, I think there are a couple of questions regarding the methodology, and I think you covered a lot in your section of the slides
Yeah.
of the stain preparations.
Yes, sir.
I think it will also be useful for the delegates if they consider getting the book. But
Yeah.
if they not trying to get the book, at least your slides
Yeah.
have the methodology
Yeah.
of staining preparation.
Yeah.
Somebody has asked, can we have the recording of your presentation, or can we have the slides? Generally, we don't ask the speakers to share the slides.
Yes, sir.
These are actually, there's effort in that for intellectual properties or maybe some
Yeah.
hospital material, something like that. But recording perhaps stays, and that's the question for Dr. Iyer itself to
It's
share
okay.
recordings. Essentially, if anything is actually available in public domain, such as books or on website, that is very well
It's recommended.
shared with anybody as educational material. I think that's what I can say.
Sir, I have given my email ID publicly, so they
Yeah.
can contact me. And this book is
Yeah.
readily available from Tata Memorial Hospital if they want to purchase.
Right. But
If
I mean,
they
generally,
don't want to, if anybody don't want, see, we will not recommend. See, we have no
Yeah.
conflict in this. So if
Yeah.
anybody wants to know a little small thing, don't want to buy, they can contact me. I will give
Yeah.
whatever information available for me.
Yeah,
There
no,
is no
that's
problem.
good of you. That's
This
very
is
nice
the-
of you. We generally do not ask the speakers to part
And
with the
this
slides.
is one of the motto of Tata Memorial Hospital to share the quality or procedures SOPs followed in Tata Hospital is freely
Okay.
available for anyone.
Okay.
So that they also should get the same quality.
Right, thank you, Salim. I think you've covered it very well, right from the sample processing, nitty-gritties of the processing, labeling, staining, and I think you showed some beautiful examples. I know we are witnessing it every day because every day quality checks can sustain and give us a good result. So I'm really very thankful to you for a wonderful lecture covering it every aspect of the lecture, including the cell block preparation, which we find actually is very useful because it allows us to do immunohistochemistry and kind of some
Exactly.
of the cancers
Exactly.
Nowadays, which we were not able to do it very freely on the cytology smear.
Indispensable.
So I think we'll end at this time the cytology talk. We'll stop now. There is a break for all the delegates up till 4:30 India time, and then we'll have the further hematology lecture later on. So Salim, from all of us,
Thank you, Doctor.
so much indeed. Thank you.
Thank you, Dr. Kedar. Thank you, Dr. Ranganathan Iyer. Well, thank you so much for giving me this opportunity. It is really, really an honor. Thank you so much.
Thank you.
Thank you all the delegates also. Okay,
Thank you. Yeah. Gautam or Bashir?
Yes, sir.
Now till 4:30 we have tea break. So shall I keep the slides or the mic, the laptop on, and come back at 4:30?
On come back. You can
Or shall,
come back to
or shall I
4:30.
shall I log out and then log in again?
You can, sir. You can log out and come again, sir.
Yeah. Okay. Then take. I will log it's to 4:30, and we'll have the hematology presentation.
Okay, sir.
Okay. Thank you so much. Shashikant? Hello? Shashikant and Shilpa, ऐकू येते तुम्हाला?
केव्हा येतोय सर येतोय
Yes, yes, thank you.
Yeah,
Meeting
yeah.
झाली का व्हायचे?
झाली अटेंड करून आलो सर
उज्ज्वला आणि सलीमचं चांगलं झालं. तुमचं
Yes, sir.
हे रेकॉर्ड केलेलं आधी दाखवायचं ना?
हो सर हो
क्वेश्चन आन्सर घेऊ.
हो सर
मणी सरांना सांगितलं ते म्हणाल मी जॉईन करतो म्हणाल. ऐकू येतं.
You are using this mic, this will not work. Oh, sir.
Shashikant, is that a call? She's on or on her mobile.
शिल्पा सर आहे शिल्पा
म्हणजे लॅग पिरियड येतोय.
हो लॅक पिरियड येतोय तिच्या मोबाईल मध्ये बंद कर.
Bashir, Gautam, are you there?
Yes, sir. Yes, sir.
Acha, ठीक है. See, Shashikant sir and Shilpa madam both are here, but we will play the recording, right? Hello.
Okay, sir. हाँ.
नहीं, नहीं. So at 4:30, you tell me when we are going live. I will introduce them.
Okay.
And I will ask to play the recording. They will attend and they will take the questions after talk is over.
Okay, sir. First, Shilpa madam or Shashikant sir?
नाही सर
Shashikant कसं करायचं?
नाही सर सीबीसी फर्स्ट सर माझं
म्हणजे आधी तुम्ही घेताय मग
Yeah.
शिल्पा घेताय.
शिल्पा.
हा.
हा.
बरं मी मणी सरांना विचारलं होतं तुमचं इंट्रोडक्शन काय करू सरांचं मला उत्तर आलं नाही. आणि तुम्ही स्लाइड दिली नाहीये मला.
हो सर सर लॅब मॅनेजर and experience of 27 years in metrology.
आणि शिल्पांचं काय बोलू? शिल्पा कुष्टे की ते त्यांचं
शिल्पा-
25 वर्ष तरी आहेच.
हो सांगा आहे सर
बरं.
Sir, you can start, sir.
हा?
You can start.
नहीं लाइव अभी नहीं है ना. 4:28 हो गया.
Okay.
4:28 हो गया है. We'll start right on time after 4:30.
Okay, sir.
If you want to see here in the speaker, introduction हो गया क्या तुम्हारा?
नहीं कर रहे सर
Introduction होने के बाद, what you do, you remove the speaker connection. Okay, you hear some connection, then A1 cut. So you can hear directly from there.
शशिकांत तुम्ही आधी काही बोलणार आहात का?
नाही सर डायरेक्टली स्टार्ट करू आपण.
आधी म्हणजे आधी रेकॉर्डिंगच चालू करूया ना.
हो
सीबीसी संबंधी आणि मग कोॲग्युलेशन संबंधी.
राईट
आणि दोन्ही क्वेश्चन नंतर घेऊ पूर्ण.
नंतर एकत्रच घेऊया 10 मिनिट.
दोन वेगवेगळी रेकॉर्डिंग आहेत.
हो 2 वेगवेगळे रेकॉर्डिंग.
बरं. Bashir, are we ready to start?
Yes, sir.
Gautam? अच्छा अय्यर सर है and I'm actually expecting our hematologist Dr. Subramaniam to join, but probably he has not been able to join. But we'll start at 4:30. I think Dr. Subramaniam will join as he can, and he can give comments after the lecture. Okay, I think Bashir, can we start?
Gautam, can we start? Gautam? Hello.
Hello, Gautam. Hello?
2 minutes, sir.
Yeah.
Sir, you can start, sir. Kedar,
Okay,
sir.
so are we live?
Yes, sir. Yes, sir.
Live, okay. Right. So thank you and welcome back once again all the delegates to this technician training program, which is to be conducted on 11th and 12th. We already had very good lecture and a very good interactions with the delegates. First lecture was histopathology taken by Mrs. Ujjwala Joshi. Cytology, various aspects of sample processing, including staining and cell block preparation by Mrs. Salim Patutara. And now we are moving on to hematology sections, essentially basics of sample processing in CBC, variety of aspects of sample processing and how we generate a report, what are the important quality control issues and coagulation. So I'm very happy to invite two of our colleagues from the hematopathology lab at Tata Hospital in Mumbai, India. And two, I am very happy that the two senior most people have joined me in taking today's lecture today. The first is Mr. Shashikant Mahadik, who's lab manager of hematopathology lab. And then coagulation aspect will be taken by Mr. Shilpa Kushte. Both are having 25 plus years of experience. In fact, in our lab, we had hematopathology was done all together, including not only coagulation, CBC, but leukemia diagnosis and molecular hematology and flow cytometry as well. It is only recently that we have separated the labs for logistical purposes. So they both have come with a plethora of experience, very well experienced hands and very wise counsel. So I'm very happy to invite both of them, Mrs. Shashikant and Mrs. Shilpa. They had actually competing meetings at the same time with admin matters, but they still have taken out their time. So we'll play their presentations first as a recording, and then they will take on the questions as at the end of the talk as live matters. So Mr. Shashikant Mahadik will have this presentation first, and then we'll have coagulation. Mr. Shilpa.
Today I'll be sharing my experience with the complete blood count.
Thank you. Yeah, we'll start.
Part analyzer.
Yeah.
I'll be discussing the principal maintenance, QC, and troubleshooting. We have two 7-part differential analyzers. One is from Siemens IDVR 2120i hematology system. It's a fully automated diagnostic instrument with the throughput of 120 samples. And if you process CBC plus reticulocyte count, the throughput is 74 samples. The analyzers uses the whole blood sample to provide the following types of results. That is the various combinations you can get the results, like CBC plus differential count, CBC plus reticulocyte count, differential count, and RBC indices. Unified fluidic circuit is the heart of the instrument. It is actually the block made up of 8 acrylic plates, which are pathway for fluid airflow values, valves, and reaction chamber. There are 5 reaction chambers: hemoglobin reaction chamber, then vaso reaction chamber. Third one is the RBC reaction chamber, retic reaction chamber, and finally the perox reaction chamber. The reagents required are various reagents like CBC time pack, DIF time pack, EasyClean, defoamer, autoretic, perox sheath rinse, and autoretic solution. The IDVR 2120i is a technical specification which gives the CBC result, differential results, reticulocyte results, absolute and percentage retic, and the CSF or body fluid, other body fluids can also be processed on these analyzers. There are various morphological flags generated. Those are WBC and RBC and platelet flags. Coming to the hemoglobin estimation method, the hemoglobin colorimetric assembly straddles the UFC block at the top. It contains the lamp assembly of wavelength 565 nanometer and 546 nanometer with cyanide interference filter. The hemoglobin reaction chamber is built in the UFC assembly itself. The hemoglobin concentration is calculated using the baseline and sample readings taken at a different specific interval during the hemoglobin sample analysis. The voltage reading corresponds to the amount of transmitted light that passes through the reaction chamber when it contains the sample mixed with the reagent or rinse. The voltage reading are then converted to the digital form by the hemoglobin interface board and sent to the analyzer CPU to calculate the optical density and derive the hemoglobin concentration. The hemoglobin method calculated reports parameters are hemoglobin in gram per detail, MCH picogram, and MCHC gram per deciliter. Coming to the hydrodynamic focusing, the cell suspension is passed through the fluid consisting the sheath rings, so that only the cells, unicellular cells flow through the channel. And when this unicellular flow of cells hits the laser light, there is a detector across which detects the cell measurement internally. The RBC method, there are two principally used, low angle light scatter and high angle light scatter. Low angle light scatter 2 to 3 degree volume is measured, and at high angle scatter 5 to 15 degree hemoglobin concentration is measured. Coming to the RBC method, the RBC scatter cytogram is graphically representation of two light scatters. High angle light scatter is plotted along the x-axis and low angle scatter plotted along the y-axis. This is the RBC method, which will give you the RBC morphological flags. The scatter plot of RBC is divided into 9 quadrants. The central quadrant corresponds to the normochromic normocytic RBCs. And as the RBC method, the CH cellular hemoglobin is also calculated in this. The histogram represents the distribution of red blood cells by amount of hemoglobin present in each cell, dependent on cell volume. The histogram has a range of 0 to 100 picogram. Cellular hemoglobin content is the mean of the RBC-CH histogram. Thus, the analyzer gives two types of hemoglobin, cellular hemoglobin and the hemoglobin calculated by spectrophotometry. Next, the platelet method. The platelet cytogram is graphical representation of two light scatter, high and low angle light scatter. Using the Mie theory, the light scattering for homogeneous spheres, the low angle light and high angle light scatter signals for each cell are transformed into volume and refractive index values. The platelet map shows the relationship between the high scatter measurement and the cell by cell characteristic by volume and refractive index. The map grid encompasses volume between 0 to 30 femtoliter. And depending on the refractive index, the platelets are calculated and it is differentiated from the RBCs. The refractive index between 1.35 and 1.35 to 1.4 is calculated as a platelet. Coming to the Retic method, this method uses a nucleic acid dye, oxazyme 750, to stain the cellular RNA. The Advia 2120 autoretic reagent isopolymetrically smears the RBC and stains the cellular RNA. Low angle laser light scatter and high angle laser light scatter and the absorption characteristics of all cells are counted and measured. The absorption data are used to classify each cell as a reticulocyte or mature RBCs based on the RNA content of the cell. So the red part is the mature RBCs, and as you move towards the B, C, D are the reticulocytes depending upon the retic content. The Retic method, the Retic volume histogram represents the overload distribution of mature RBCs represented by the red population, and the small blue population correspond to the reticulocyte count. Calculating the neo-retic parameter CHR, cellular hemoglobin content reticulocyte. Mean of the retic CH histogram for the reticulocyte population is CHR. CHR is a sensitive indicator for amount of utilizable iron. It shows the functional iron level of the previous 3-4 days. Iron deficiency anemia, so CHR is less than 28 picogram. Hence, it is useful parameter for diagnosis of iron deficiency anemia, evaluation of response of iron therapy, and monitoring the erythropoietin treatment. Immature reticulocyte fraction IRF indicator of changing in the erythropoietic activity, mainly in chronic renal disease, monitoring the after bone marrow, stem cell, and renal transplantation in different types of anemia. Now coming to the WBC method, differential of WBCs goes on two parallel channels. One is peroxidase and the other is the basophil channel. Coming to the perox method. In the perox method, x-axis correspond to the peroxidase activity, while the y-axis correspond to the light scatter or cell size. Lymphocytes being the smaller in size and negative for peroxidase, they are formed as a cluster in this particular region. There are some large lymphocyte, a typical lymphocyte of blast cells, which will occupy the position just above the lymphocyte because they are peroxidase negative. This particular population of cell is called LUC, large unstained cell. As you move towards the right side of the scatter plot, the peroxidase activity increases. The cluster of cells in the region 6 correspond to the monocyte because some of the monocytes can be weak positive or negative for myeloperoxidase activity. This particular region is for the 7th region is for the neutrophils and immature granulocytes, and the 8th region correspond to the eosinophil. This perox method is very important in diagnosis of APML because it gives the certain types of scatter plot which correspond to the APML cases. APML is an emergency, so detection of this is very important in diagnosis of APML. Next principle used for this particular analyzer is the BESO method, in which all the cells except basophil lose their cytoplasm and only the basophil will be intact. And accordingly, the basophil will occupy the 4th position, 4th cluster. The first region correspond to the NICE, second is are the blast cells nuclei, and third one is the mononuclear cells, and fifth is the polymorphonuclear cells. Depending upon the nuclear density, they are distributed in this particular manner. Now, depending upon the perox method and the basophil method, the combination of two graphs can lead to the various types of leukemia, because in leukemia, different types of leukemia, you get a different scatter plot, and you can detect you can suspect the various type of leukemia by studying this various scatter plot. Coming to the maintenance is as important as your quality of the instrument, because if you keep maintaining the instrument at the proper state, that will help you to give the good report from the analyzer. The types of maintenance may be daily, weekly, monthly, yearly. That is a preventive maintenance before calibration. And as needed, that is while troubleshooting or whenever there is the instrument malfunctioning, the maintenance is required. So you have to have some daily maintenance like startup, perox flow cell wash, basophil cell wash, and system wash. And you can maintain the log for the same. Startup is nothing but just giving all the reagent prime. The instrument runs as a background cycle count to obtain the BESO WBC background count and other parameters background count. The background is within the range, that is in green color. You can proceed with your control material. If any result is out of range, select and refresh the startup tab to run another background count till it comes close to the 0. Coming to the other types of maintenance, like because there are perox method and BESO method, the corresponding flow cells need to be maintained properly. The perox method, in the perox flow cell wash, we use hypo, while the perox cell wash, while the basophil we use the hypo, diluted hypo, while in the perox we use the easy clean. System wash is performed so as to all the grooves and apertures are cleaned. Weekly maintenance includes shear wall cleaning, because shear wall is the main part of the instrument which divides the blood sample into three various segments, and then the dilution is done. The aspiration plus path also needs to be clean. A drain filter, Perox chamber cleaning, and the clean rack bed also is important. Shear wall can be cleaned by removing the screw 4, 3, 2, 1 in that manner, and the ceramic part can be cleaned with the sodium hypochlorite 5% minimum for 10 minutes, and reassemble shear wall once you're done with your washing cycle. Aspiration path also needs to be cleaned. So it is clean aspirated because the aspiration depends upon the various walls like 72, 73, 74, V1, 47 in sequence. So it is diluted hypochlorite is taken to clean this wall cleaning. Filters, there are various filters like drain filters which needs to be cleaned regularly. Perox chamber cleaning, Perox chamber is maintained at this particular temperature, and since there is a Perox region going on in the temperature, this has to be cleaned on the regular basis. Needles, as needed maintenance of ADVIA, cleaning of clot detector filter, replace syringe plunger, clean air circulation filter which is placed at the back side of the instrument. Clot detector filter is the filter which is placed in front of your aspiration tubings and which requires the cleaning because there are some minute fibrin clot getting attached to the filter. So open the aspiration nozzle carefully, clean the filter gently on tissue paper and close it tightly. Auto sampler troubleshooting tips are eject the rack in the sampler status line. Message appears in the analyzer is powered off when the turn on again. Messages that appears are communication error with analyzers, analyzer computer not connected. There is a leakage in the sample fitting on the centering column. Finger tighten the fitting about 1.5 turns. The error message input queues get open appears occasionally when the starting with the auto analyzer. The error appears sometimes when a rack is waiting in the input shuttle area. Move the rack back to the first position in the tray and then start auto analyzer again. Coming to the troubleshooting, there are some errors are displayed on the screen like MCSC CSCME error. This flag is triggered if the difference between MCSC CSCM value is greater than 1.9. The corrective action is multiple occurrence of this flag can be system related and or a sample related as shown follows. There could be the sample related flag like lipemia sample leukemia with high count, neonatal NRBCs, hemolytic anemia or coagulopathy. System related flag, if another flag appears along with the comparison error, troubleshoot that error first. To determine the faulty channel, run the same normal whole blood sample 5 times to check the precision of RBC, MCV and HGB. These run normal level control to check the then run the normal level control to check the accuracy. If all results are acceptable, then calibrate RBC, MCV, CSCM and hemoglobin parameters. Comparison error with WBC B and WBC P. WBC B stands for basophil WBC and C stands for peroxidase WBC. The corrective action multiple occurrence, especially for the consecutive samples. It could be sample related or it could be a system related. So these flags are specific to the specific reagent, specific channel. So accordingly, you have to clean and give the wash to the particular channel. Then the baso or irregular flow reagent. This flag results when there is a irregular flow reagent on the baso channel. This flag triggered when the cell counting rate is erratic because of hydraulic disturbance in the baso channel. Okay, the corrective action, check baso reagent, check baso hydraulics, and check the sheath delivery. Peros irregular flow rate, that is PX IFR, is corresponding to the Perox reagent channel. Check the Perox reagent, check the Perox hydraulics and sample delivery, check sheath delivery, check the pressure and volume reading. RBC irregular flow rate. This flag trigger if the cell counting rate is erratic because of a hydraulic disturbance in the RBC platelet channel. The flag is triggered if the flow uniformity value is greater than 3.2%. So in this case, you can have to check the RBC reagent, RBC hydraulics, sheet delivery, and pressure and vacuum reading. High power low, that is SGB, PL, pH, you have to adjust the hemoglobin baseline, perform the reads, and replace the hemoglobin lamp. Perox power low, perform the sheath reagent check the perox lamp alignment, and replace the tungsten halogen lamp. Platelet noise, LPAT or anisocyte flag, or LPLT or micro flags are triggered. LPLT is a large platelet population. The corrective action, the perform the cleaning of the platelet aperture. The laser power low flag trigger if the laser light is intensity is in the RBC vasoretic channel. The result flag are various RBC, SCT, MCV, MCHC parameters. Corrective action, flush the RBC flow cell. Perform the sheath reagent check, remove and clean the RBC vasoretic flow, and replace the laser light. Now coming to the quality control of the hematology analyzer. First, what are the indication for calibration? At the time of installation, you have to perform the calibration. Calibration is nothing but the fine-tuning of your instrument using a reference material calibrator. If your QC data suggests, then you require to do the calibration, relocation of your analyzer, change of major part which is affecting your reading, and as per lab policy. As per NABL, at least once in a year, you have to do calibration of your analytical reagent, analytical instruments. Coming to the IQC, internal quality control, background, then running 3-level QC control, precision, comparative are the main steps of your internal QC control. Background, every analyzer states that your background count should be less than the limits given by the manufacturer. The QC material, you have to run all the 3 levels. If you are working 24/7, twice in a 24 hours, you have to do the QC run. When you receive the QC, first 10 days or 11 days, you go by the manufacturer's range and mean. And after 10 readings, you have to update your lab mean. That lab mean will be more stringent criteria for QC. So lab mean, once you update the lab mean, then you have to just monitor the LJ chart and see the QC is proper or not. Precision sample, it could be a fresh sample or a written sample with the known values. So you have to do the precision sample because you want to know the status of your instrument throughout the day. So precision sample frequency can be either 30 sample or 1 hour as in our lab, but you can state a policy according to your workload. Comparative sample is done between the, just to do the comparative between the 2 or 3 instruments if you have. The lot verification plays an important role. Once the reagent lot is changed, then you have to do the lot verification. For lot verification, you have to run at least 2 samples before and after the change of lot reagent. Coming to the external policy assurance scheme for CBC and RETIC, we participate in AIMS on an international, non-national basis, and CAP for international basis. The AIMS sends quarterly 1 CBC sample, 1 stained reticulocyte smear, and 1 stained peripheral smear, and we report on it, and then they give us their score, Z score, or whether your results are within limit or not, satisfactory or not. CAP we run thrice in a year, and RETIC samples are sent twice in a year. So we perform the internal proficiency testing for our staff. So whatever the slide from AIMS, CBC, peripheral smear, and reticulocyte smear, we give it to all our technical staff. Then the results are compared, and then we give them scoring. So as a proficiency testing, we do this internally. Coming to the DHX 800 principle, which is another analyzer, the principle involved here is different as we see in the ADVIA, the principal uses spectrophotometry for the hemoglobin count. WBC counts are measured by the flow cytometry, light scattering, and differential by peroxidase and Bezo method. Here, the principles are different than the one we saw in the ADVIA 2120I. So here the WBC, RBCs and platelets are counted depending on different principle. Coming to the DHX is a 5-part differential analyzer from the Coulter family, which depends on the impedance principle and VCS technology. So what is the impedance principle? The impedance principle is that when the cell passes across the aperture, there is a constant electric current flowing across the aperture. When the cell passes, it will impede or it will create an obstruction to the current, and it will create a pulse. The number of pulses are correspond to the number of cells passing through the aperture, and the volume of pulse correspond to the size of the cell passing through. So this is the representation diagram. The cells are passing through the aperture, and there is a constant electric current across the aperture. Passage of WBC through the aperture. So the different cells will have different pulses and size of the pulses, depending upon their size and internal composition. The big pulse is correspond to the big size of cell, and small correspond to the small size of cells, maybe lymphocyte or the sample preparation. The aspiration pump activates and aspirate 165 microliters. Then it is diluted. For WBC, the dilution is 1:250 ton, and for RBC, the dilution is 1:6250. Dilution is done. After the mixing and incubation of sample, the reagents, 6 inches of vacuum and aperture current are applied to the aperture for measurement of cell count and cell volume. All pulses are generated, are collected and sent to the digital measurement system manager. There are some technology is involved which will try to minimize the error and give the at close to the correct values. Sweep flow is one of these. Sweep flow is the steady stream of diluent that flows behind the RBC aperture during the sensing period, which lines up the cells in a single file while passing through the detecting aperture. This prevents the cells from re-entering the sensing zone and counting of cells twice. The counting and sizing, the RBCs, WBC bars each have 3 discrete aperture that function as an independent system, utilizing the Coulter method to accurately count the size and cell. Pulses that represent cells from 2 to 20 femtoliter are classified as platelet, while pulses that represent a cell more than 36 femtoliter are classified as RBCs. Pulse reading helps to give the correct count when the cell passes through the aperture near the edge or at an angle rather than in the center. They create a typical pulse. Such pulses are excluded from the analysis because they distort the true size of the cell. This prevents the atypical pulses from influencing the size measurement. Coincident correction: occasionally more than one cell passes through the aperture at one time. When cells coincide, only one combined pulse is counted. As the frequency of coincidence is proportional to the actual count, the system automatically corrects the result for coincidence. Now, hemoglobinometry, the lytic reagent rapidly and simultaneously destroys the erythrocytes and converts the substantial proportion of the hemoglobin to the stable pigment while it leaves the leukocyte nuclei intact. After the WBC are counted, the analyzed WBC dilution drains into the hemoglobin cuvette for hemoglobin measurement. Hemoglobin is measured photometrically at 525 nanometer. The absorbance of pigment is directly proportional to the hemoglobin concentration of the sample. A blank is introduced into the cuvette during each operating cycle. The hemoglobin blank provides a reference to which the sample signal is compared. The differential count in this analyzer is given by the VCS technology. The Coulter VCS established the WBC differential technology using the measurement of individual cell volume, high frequency conductivity, and a laser light scatter. Volume analysis: direct current, a low frequency direct current measures the size of leukocyte based on its volume. It has been evaluated as possible agent to the differential white cell count. Conductivity analysis, the cell walls act as a conductor to the high frequency radio frequency current. The current, while passing through the cell walls and through each cell interiors, detects the differences in the insulating properties of the cell components. The current characterizes the nuclear, the granular constituent, and the chemical composition of the cell interior. The light scatter analysis, blood cells are passed in a single stream to the detecting device called flow cell. This flow cell will have a laser device focus on it as the cell passes through the laser light, which is a monochromatic. It will struck and scatter. The light scatter at angle of 10 to 70 degree is used by the VCS instrument. The light that strikes the cells is scattered at angle proportional to its structural features. Each cell, as it passes into the laser beam, is measured according to its surface features, structure, shape, granularity, and reflectivity. Like this, the lymphocyte will scatter less light. The scatter of monocyte will be little more than the lymphocyte because some monocytes have the granules also. Scatter of neutrophils and eosinophils will be the highest scatter. VCSN analysis. VCSN module is responsible for the control sample preparation, delivery of prepared sample to the flow cell analysis for WBC differential reticulocytes and NRBC. The VCSN module includes air mix and temperature control, that is AMTC module, multi-transmitter module, that is MTM module. Sample preparation of differential NRBC and retic occurs in the mixed chamber of AMTC module of the VCSN module. Blood sample delivered by SAM is dispensed into the appropriate mixture chamber. Next, the temperature control reagents are added and air is mixed using a jet of air at 4 psi. Then the prepared sample is transferred into MTM where the cells are counted in an isometric sample stream. Multi-transducer model MTM, the DHX replaces the TTM with the MTM. The MTM measures additional multiple angles of light scatter, the major improvement over the single light scatter measured by the TTM. The MTM utilizes the flow cell to pass particles through the sensing zone, one particle at a time, and a diode laser to eliminate the particles. The eliminated particles both scatter and absorbs the portion of light incident. Sensors strategically placed around the flow cell collect the scattered light of interest. An additional sensor placed in the laser path measures the amount of light removed due to the light scatter and absorption. This measurement is called axial light loss. There are various scatter and which measures the various components of the cell. The axial light loss, low angle light scatter, upper median light scatter, median angle light scatter, and so on. So the volume measurement by Coulter principle is the key parameter in transforming the 5-part differential plot. Rotated light scatter is a transformation of data derived from the ratio of the log of the LS divided by the DC, that is volume pulse peak information. This rotated light scatter function has affect the size component, yielding the measurement that is more related to the internal structure. Derivation of opacity. Opacity is the transformation of data derived from the ratio of RF components obtained during the data acquisition. It is calculated for every individual cell measurement or event and has an effect for removing the size component, yielding the measurement of is more related to the internal conductivity of the cell. 2D data plot differential analysis. 5-part differential shows main population, lymphocyte, monocyte, neutro, eosinophil, and basophil, plus the non-white cell population. 5PD1 data plot shows volume is plotted on the y-axis, while the rotated light angles light scatter is plotted on the x-axis. The 5PD2 data plot shows volume on the y-axis and opacity on the x-axis. 2D data plot NRBC. 2D data plot NRBC shows two main population, NRBC and WBC. On the NRBC1 data plot, axial light loss is shown and on x-axis, and rotated low angle light scatter is on y-axis. This plot is very important because if you have the malarial positive cases, it can detect very well. There will be a small green population which will be occurring in the data plot that corresponds to the malarial parasite population. Coming to the maintenance of the troubleshooting and maintenance of the instrument, if you detect and resolve the plug aperture, the plug aperture or WBC or RBC aperture can increase the likelihood of vote outs and sample flagging. This can cause elevated background count. The aperture can plug by the protein buildup, cellular debris, or a small piece of tube stopper. In this case, you have to give the ZAP aperture and clean aperture. The ZAP aperture procedure is simpler procedure and may be all that needed to remove the blockage or a buildup. So always try to ZAP aperture procedure first. It applies the voltage across the WBC and RBC aperture, and for cleaning aperture, bleach is used. Bleach the aperture to address decreased cell volume, increase MCV volume, or increase vote outs. A jam cassette. Remove the transport shield, select the silence any alarm, and then slide the jam cassette to the right to disengage it from the mixture wall and remove it. Return to the transport shield to the original position. Flush flow cell. Flush flow cell procedure is used to clear the blockage or the flush debris from the flow cell. The flow cell comprises of an upper and lower chamber connected by an aperture. The flush flow cell with a cleaner procedure flushes both chamber with cleaner. Timer lets you leave the cleaner and in the flow cell for from 0 to 30 minutes. The system removes the cleaner, cleans all the areas contacted by the cleaner. Summary, the DHX analyzer impedance technology gives the cell count and cell size. VCS technology gives differential count, reticulocyte count, and the NRBC count. Analyzer give excellent throughput and outcome, require minimum maintenance suitable for hematology labs to set up as required little space. These are the two analyzers I have just discussed. Then I will hand over to my colleague, Mrs. Shilpa.
Okay, Shashikant, thanks a lot. Many thanks. Very practical points. It shows the volume that you're experiencing and the maintenance of variety of types, troubleshooting. Thank you so much. We can go on to the next. Recording with Mrs. Shilpa Kushte. Before that, may I just take a minute to welcome Dr. Subramaniam, please. Dr. Subramaniam is in charge of the hematopathology lab at Tata Memorial Hospital, and he looks after all the, not only CBC aspect, coagulation aspect, but also leukemia aspect, flow cytometry aspect, molecular hematology aspects. And he has been driving this for last more than 12 to 15 years, I think. So welcome, Dr. Subramaniam. I know you have been busy in other lectures elsewhere. So thank you, special thanks to you for spending time. And I will ask for your comments after the coagulation recording. Thank you, Shashikant. Thanks a lot. Yeah. I welcome Mrs. Shilpa Kushte for her coagulation.
The basics of coagulation.
Yes, please. Yeah.
As we all know, coagulation is a part of hemostasis. Hemo means blood and stasis means to remain. Hemostasis is the process where the stoppage of blood is done, which is required for whenever there is a vessel injury. It is divided into two stages, primary and secondary. Primary hemostasis include platelet and vascular response to vessel injury, and secondary hemostasis include coagulation factor response, which is response to the same vessel injury. Together, platelets, vessels, and coagulation factor combine to stop bleeding and allow for the vessel to repair through formation of a stable platelet and fibrin plug at the site of injury. So there are 13 coagulation factors involved in the coagulation cascade. Amongst them, factor 7, that is pro-converting, has a very short half-life, that is 5 hours. The different categories of disorders may be found in hemostasis, like vascular and platelet disorders, coagulation factor deficiencies, or specific inhibitors which are present in the patient plasma, or fibrinolytic disorders. There are many tests available which can evaluate these disorders, like platelet count, peripheral blood smear examination, IV bleeding time, or platelet function test using platelet aggregometer, prothrombin time, which measures the extrinsic and common pathway factors, activated partial thromboplastin time, that is APTT, which measures the intrinsic and common pathway factors. In prothrombin time, in thrombin time, excess of thrombin is used to convert fibrinogen into fibrin, and it measures the common pathway. Mixing studies, which is very simple, but whenever there is a PT and APTT abnormal results are found, we can do this test. And if assay is corrected, it is due to the factor deficiency. If it is partially corrected or uncorrected, it is due to the inhibitors. Single coagulation factors are also available, like factor 8, factor 9, factor 13, factor 5 laden. Assays for fibrin degradation product, which measures the fibrinolysis. The example of the test are FDP and D-dimer. While doing this test, there are many variables are important in laboratories, like pre-analytical variables, analytical variables, and post-analytical variables. We'll see one by one. Pre-analytical variables contribute around 70% of the erroneous result when we do any test. So for the coagulation, fasting of the patient, or patient should be on light fatty meal, because it will increase the sensitivity of the optical based assays. Patient should be calm and relaxed, because physical and mental stress can increase the coagulation factor, especially factor 8. Tourniquet should be applied more than, it should be less than 1 minute, and this will also, if it is not, then it will also activate the coagulation factors or fibrinolytic system. Venous blood is prepared because it will duplicate the, it will able to do the duplicate testing. Venipuncture should be atraumatic because it will otherwise cause the hemolysis. Blood should be free flowing, and there should not be air bubble, because this can lead to hemolysis. Evacuated tube system is preferable because it prevents the hemolysis because of the syringe needle collection. The anticoagulant of choice is 3.2% buffer sodium citrate instead of 3.8%, because in 3.8% sodium citrate concentration is high, and which can lead to falsely lengthened clotting time, especially when we use the calcium-based assays like PT and APTT. According to the NCCL's guideline, first tube should be blood culture, but if it is not there, then we can check the coagulation tube as the first tube. Blood to anticoagulant ratio is very important in coagulation testing. It should be 9:1. Elevated hematocrit is found especially in the polycythemia vera, and this can lead to spurious coagulation result, because in when the when the hematocrit is elevated, we have a less amount of plasma, and it will use the calcium which is present in the reagent, and then we'll get the prolonged PT and APTT. The transportation should be done at room temperature, because cold will increase the coagulation activate the coagulation cascade, and that's why we should not transport our coagulation samples in cold. The time should be within 4 hours after the collection, because all the labile factors will get deteriorated when the time is more or prolonged. Centrifugation is required to do the platelet per plasma, and the platelet count should be less than 10,000. In our lab, we are using 10,000 G. In our lab, we are using 2,000 G for 10 minutes. Just to emphasize more on underfilled and overfilled tubes, what will happen? When there is an underfilled tube, we have an excess of sodium citrate present in the blood, and it will consume the calcium which is present in the reagent. So you will get a prolongation of PT and APTT. Overfilled tube, we have a less amount of sodium citrate. So there are chances that fibrin clot may be present, or the activation will start first only, and then we'll get the shortening of PT and APTT. Coming to analytical variables, the instrument which we are using, which methodology has been used in the instrument is very important. We should have the reagent and instrument should be compatible with each other. And that's what many a times we are using the same company's reagent. Calibration plasma is required to plot a standard graph or standard curve, especially for the fibrinogen and the D-dimer assay. Controls are used to check the reproducibility of the reagent and the instrument. Coagulation test can be done in different ways, like using the manual method or using the coagulometers. Like automated coagulometers are also available and semi-automated coagulometers. Manual method, you have to add reagent and plasma manually, but this test is very laborious and we have the problems with the detection of endpoints, and it is also subjected to human errors. But still, in some cases, it is the gold standard according to the WHO. Semi-automated system, we have to add reagent and plasma manually. So that is also very laborious and subjected to human error. So automated coagulometers have the improved accuracy and precision, and it enhances the efficiency, safety, and diagnostic capabilities in hemostasis testing. There are many methods for the endpoint detection, like mechanical method uses electromechanical principle or magnetic steel ball. In optical methods, we have photo-optical, nephelometric, chromogenic, and immunogenic. We'll see them one by one. Mechanical methods have some advantages, like we can use the small sample and there is no interference due to lipemia, bilirubinemia, and hemolysis. But the disadvantage is we cannot measure the kinetics of the clot formation and the problem with the endpoint detection when there is a low fibrinogen level. Coming to photo-optical method, graphics on clot formation can be observed. Optical checks are there in some instrument for the hemolysis, lipemia, and ecteric sample. But the very short coagulation period will go undetected in the photo-optical method, and interference because of the hemolysis, lipemia, and bilirubin can be observed. Nephelometric, using the nephelometric principle, we can do clot-based assays and immunoassays. It has a high volume multiple assay technology, but it limits the available test and cost of the reagent is very high. In chromogenic method, we can use fully specific assays and also there is a improvement in precision compared to the clot-based assays. But there are limitations that instrument wavelength has a very limited wavelength and it requires a large test volume for positive cost-effective ratio. Cost of the instrument and reagent is high. Using the immunological method, we can automate the time-consuming manual methods and increases the number of possible tests. But there are very few assays are available using the immunological method and cost of the instrument and reagent is high. But using the automated coagulometers, we can do many clot-based assays, immunological assays, absorbance tests, and special coagulation assays like factor V Leiden, lupus anticoagulant screening, and so on. But there are analytical limitations because of the automated coagulometers, like a lipemic sample, we can get the lipemic sample because of the high triglyceride level, more than 2000 milligrams. Then we can remove this large lipemic particle using the ultracentrifugation or using the high centrifugation, that is 10,000 G for 15 minutes. We can use N-hexane, which act as an organic solvent. Ecteric sample will be observed when there is a bilirubin level is 2.5 mg per dl and higher concentration will interfere with the coagulation test. To overcome this problem, we can use higher wavelength in our instrument. Hemolyzed sample can be observed when there is a lysis of RBCs, and this definitely not to be used for the PT and APTT test. So we have to recollect the sample when the sample is hemolyzed. Now coming to different tests, first is the prothrombin time. For doing the prothrombin time test, we require a platelet poor plasma and a PT reagent, and it includes the tissue thromboplastin, phospholipids, and calcium. The tissue thromboplastin, what is the origin, will depend on the source of tissue thromboplastin we have acquired from. Prolonged PT, that is, can be observed in oral anticoagulant therapy like warfarin and acetone, liver diseases, vitamin K deficiency, then factors 7, 10, 5, 2 deficiency or defect. Shortening of PT can be found in poor quality venipuncture, cold activation of the sample if the plasma is stored at cold temperature, and because of the administration of recombinant factor 7. Activated partial thromboplastin time, that is APTT, we require platelet poor plasma, APTT reagent which contains phospholipid, and the activator. Depending on the activator, the results will be observed. For example, we can use micronized silica, then colloidal silica, kaolin, ellagic acid can be used as an activator. We have to incubate this and then add the calcium chloride. Prolonged APTT is found in disseminated intravascular coagulation, liver disease, massive transfusion, administration of the or contamination because of the heparin, circulating antibodies if they are present in the plasma, and factor deficiency of factor 8, 9, 11, or 12. Shortening of APTT can be found when there is a difficulty in venipuncture, fibrin clot present, pregnancy, and prothrombotic changes. As I have already told you, mixing studies can be done whenever there is a high PT and APTT results are there. We can use 1:1 dilution, that is 1 part of blood, that means plasma, and 1 part of the normal pool plasma, and or 4 part of your patient plasma and 1 part of your NPP. The 4:1 dilution is used when there is a mildly prolonged APTT is observed, and it is more sensitive for detecting weak inhibitors, and it also detects the lupus anticoagulant in presence of oral anticoagulant therapy. Instead of normal pool plasma, we can use H plasma or adsorb plasma also. The interpretation of mixing study is that when it gets corrected, that is means first the PT and APTT is prolonged, but after doing the mixing studies, if it gets corrected, then it's because of the factor deficiency. And if it doesn't get corrected, then it's because of the inhibitors present in the plasma. Fibrinogen test can be done by Claus method, which is a gold standard method. It is a functional assay based on the time for fibrin clot. PT-derived fibrinogen assay is based upon the prothrombin time, and some instruments can do this PT-derived fibrinogen along with prothrombin time. Immunological method measures the fibrinogen antigen rather than fibrinogen, functional fibrinogen, and gravimetric method is based upon the clot weight. Decreased fibrinogen levels are found in afibrinogenemia, hypofibrinogenemia, decompensated liver disease, viral hepatitis, disseminated intravascular coagulation, and in hemodilution. Elevated fibrinogen are also important. It is elevated in increasing age, pregnancy, acute phase reactant, oral contraceptives, disseminated malignancy. Coming to D-dimer assay, in early 70s, we used to use staphylococcal clumping, latex fixation, agglutination methods. But in modern assays, we use monoclonal antibodies for doing the D-dimer test. And the endpoint detection is based on the immunofluorescence, latex-enhanced immunoturbidometry, or chemiluminescence. Elevated D-dimer levels are found in DVT, that is deep vein thrombosis or pulmonary embolism, venous thromboembolism, disseminated intravascular coagulation, in recent surgery. In APML, we observe the D-dimer level high because abnormal promyelocytes act as a procoagulant. In normal pregnancy and in abnormal condition like eclampsia. Coming to post-analytical variables, the report format should be reader-friendly. Poor transcription makes a lot of difference because wrong report to the wrong patient or copying of the wrong result makes a lot of difficulties. Manual transport of result can increase the turnaround time. In coagulation, internal quality control is very important. For PT and APTT, daily we run normal pool plasma, which has been prepared in-house, and it is considered as a normal control. High level of control, that is low abnormal control, is commercially procured. Normal pool plasma is used as a control along with every test batch. Low fibrinogen control is used specifically for the fibrinogen by Claus-based assay. And for D-dimer, we are using normal and high controls, which is commercially procured. The values which has been obtained for PT, APTT, fibrinogen, and D-dimer are entered in the QC program for generating Levy-Jennings charts. We are using MedLab QC programs, and the percent CV is also monitored. So if the controls are out of range or they are not coming in an acceptable range, so what will be the wrong? Either it's with a reagent or with a control or with an instrument. So we have to rule out one by one. We have to check the reagent deterioration, that is any change in color or turbidity of the reagent. When we are doing the test, whether the reagent is insufficient or the expiry date of the reagent. If the problem is with the reagent, then we can use a fresh reagent and check the result again. We have to check for the lot change also, because calibration is required for fibrinogen and D-dimer tests if there is a lot change, and lot verification has to be done for the PT and APTT test. MNPT exercise, that is mean normal PT exercise, has to be done for the prothrombin test. If the problem is with the control, then we have to use the fresh control, and we have to check the refrigerator temperature also, because our reagents and controls are kept in the fridge. If the problem is with the analyzer, we have to check which error machine has given, and we have to refer to the operator manual for the troubleshooting. If the problem still persists, then we have to call the service engineer. Coming to external quality assessment scheme, CMC Vellore runs the ISHTM program, and we are participating in the BioRad for the external quality assessment scheme. Thank you.
So please unmute. Please unmute.
Hello, hi, Shilpa. Thank you very much for a comprehensive talk. You began with basics of coagulation, but you covered pre-analytical matters, reporting matters, as well as practical points regarding refrigeration, citrate pH. I think is a percentage. I think that's very well, and I'm really grateful to yourself and Shashikant for covering this both basics aspects. I personally have found it very useful, although my reporting usually practices now histology and cytopathology, but I've found it very useful. May I ask Dr. Subramaniam for his comments, please?
Yes, thank you, Kedar, for having me as a part of this program. I think Shashikant and Shilpa have given an overview, as well as what are the common issues in coagulation as well as cell counters. I would like to reiterate that there may be some issues which are of other companies and other models which may not get covered, but a majority of the issues are common across models and problems. So in coagulation laboratory, one of the areas we have not covered is the thrombosis per se, but it is just because it's a more specialized kind of work, and many of the work is more molecular nowadays for thrombotic workup than in terms of a routine. Though there are a few thrombotic disorders like say your lupus anticoagulant, which is commonly done, but which is basically the reagent in which you would be using similar principle to what you do for your APTT. But lupus coagulant requires a more different kind of an approach to do this. We are not covered it because that's not generally done since our hospital is an oncology hospital, these kind of cases don't come. But if you are going to deal as a part of say nephrology unit, or you are going to deal at the rheumatology unit or other medicine units, lupus anticoagulant test becomes a very common test which is used in the coagulation.
Right. Thank you. Because this program is actually for Southeast Asia region, but predominantly we have people from India, but there are substantial number from Sri Lanka and few from Pakistan as well. May I ask a general question that if suppose we are running a lab and coagulation studies and you require external quality assessment scheme of participation, do we have everything available here, or do we have to subscribe to Western countries for such coagulation external quality assessment schemes?
External quality assessment schemes, the CMC Vellore conducts one. Then
Okay.
Biorad as a company is running a good program. So this Biorad program is a commercial program which is, I think, very widely available. There are other European and Australian groups also who run similar programs. So those are there. So depending upon the test, the commercial programs are always there. I think a big range is available, including, I think, ISTH also runs International Society for Thrombosis or Hemostasis. I think, I'm not really sure, but I think they also run a program for certain specialized, very highly specialized stuff. The quality control programs are more deficient in thrombosis and coagulation mainly for the platelet functional assays.
Okay.
They are a problem because it's not very easily available to get material which is stable, which will be reproducible, which can be run as a quality control material.
Okay, right. Thank you. I think we are just about coming to close end of the program. I must thank all the speakers who participated and also Dr. Subramaniam, Dr. Shashikant, and Shilpa for taking out their time from busy admin matters to actually spend time with us. A couple of housekeeping arrangements or announcements that I will ask all the delegates to please give us feedback, and then only we will actually try to give you the attendance certificates. And secondly, tomorrow we start again India time, 2 p.m. or 1400 hours India time for microbiology session, which will cover serology and molecular diagnostics of infections. Dr. Iyer is our colleague is here. Dr. Iyer, do you wish to add anything as concluding remarks? You're on mute.
Please unmute.
Yeah.
I think you've said it all, but then all that I would say is that it's really very heartening, extremely useful to listen to real life experience, particularly when senior technologists talk about the difficulties, the hurdles that they have come across while trying to follow standard methodologies, and then how they have had to modify certain procedures and how they've been able to validate and verify those procedures before putting them to routine practice. That's something which is very heartening to listen to, particularly coming from a huge institute like the Tata Memorial Hospital. I think the sessions were very, very well done, both histopathology as well as hematopathology. And yeah, we again come back tomorrow afternoon to 2 p.m. And we hope and pray that we do a fairly good job of trying to explain to our technical colleagues on the small nitty-gritties of microbiology, serology, and probably, if time permits, touch on molecular.
Okay. Right.
Because it's a huge chunk. Even if we have 3 hours, it's a massive chunk to do all of that in 3 hours. But then we'll try and do our best with a short break in between. Thank you so
all,
much, folks.
Thank you all, and I must thank IT support people, video technology, conference technologies, Mr. Bashir and Mr. Madan and his team, Gautam, and thank you very much. And we meet again tomorrow, 2 p.m. India time.
We request the video conference technology people to kindly save today's recording for future use, because it is very useful. And it's not just to share with the Royal College of Pathologists as evidence for having conducted the session, but then I think it's very, very important it may be very useful for all of us at a later date, particularly practicing technology.